Welcome to second day of our meeting. Today we are starting with a very good topic. Is surgery is necessary? This is a very difficult part of for surgeons. We are doing go better and then better, but sometimes we are doing surgery less than less. We are discuss the surgeries going on upper and or donor part of the part of the our surgery. We will discuss three topics, but one of the colleagues couldn't come to meeting. We are talk about two topics. First topic is radio frequency ablation. Mr. Yazan couldn't discuss. Yeah, Mr. Yazan is not here. Ash will, yeah, Mr. Ash is will will set that the topic. The topic is radio frequency ablation for the tumors. Your session is yours.
That's an important disclosure. So I don't do this anyway. But what's the rationale for doing minimally invasive surgery? I think we need to understand that the whole fashion now is of de-escalation. We want to avoid surgery where we can, or we want to avoid invasive surgery or ablative surgery where we can. And the non-surgical options obviously have a number of benefits. There's decreased risk of complications from anesthesia. There's improved cosmesis because there's no volume loss, there are no scars. and the recovery is short. It can be done under local anesthesia, mostly as an outpatient procedure. Some patients are a high risk for anesthesia. They have lots of comorbidities, poor functional status, increased risk of post-surgical complications, especially in smokers, diabetics, high BMI people. So this is an option, an attractive option for them to reduce their complication profile. It does improve cosmesis and because of minimal scarring. So as a consequence, patients will benefit from social well-being and psychological well-being. Now, if you Google cryoablation, which I did, and then radiofrequency ablation, which I also did, you have about 34 publications that come up in 2021. That's the maximum it reached. So there was an upsurge there somewhere in the mid-2015s, 2014s. And then you can see that the buildings are coming down. So it's not something which is growing in fashion. The mechanism of action is very simple. It causes cell death or induces cell death by burning them or increasing the temperature so much that they undergo hypothermia and then cell death. So it's the most extensively studied out of all the minimally invasive approaches that are known to us. A percutaneous needle is induced in the tumor or in the center of the tumor under ultrasound guidance, and then they induce an alternating current, so an AC current instead of a DC current. So what happens is the polarity keeps changing. As the polarity changes, the electrons move that way, then they move that way, then they move that way, then they move that way, and they bang against each other and they heat the tissue up. So the tissue then becomes hypothermic, and then you get cell death from frictional heating. The local temperature can increase to about 100 degrees in centigrade, which is quite high and not compatible with any cell life. The heat also dissipates as a function of distance, and that can be calculated. So it's very easy to calculate the dosimetry required for radiofrequency ablation. It was first used in colorectal metastasis, and now it's being used more and more in breast cancer. And why breast cancer? Because it's a superficial organ, it's easily accessible, there's nothing that interferes with it, it's not invasive into the body, we don't have to monitor the patient too much, it's very easy to monitor the patient as well. So is everyone suitable for cryoablation or, sorry, radiofrequency ablation? Sorry, I keep saying cryoablation because even the presentation says cryoablation on top. So it depends on the tumor extent, the tumor size. If you have a well-defined tumor, it's easy to calculate the dose because the dose moves, like I said, as a function of distance. If you have something with irregular borders, lots of DCIS, then that is not an ideal patient for radiofrequency or RFA. That's why an MRI is sometimes recommended to know the true extent of disease and potential multi-site disease before you actually treat the RFA. Because if you have multi-site disease and then you get a higher local relapse, you'll blame the RFA rather than the fact that there was multi-centric disease. But now we know from the other trials and the data that we saw yesterday that MRI actually doesn't help. But since I don't do it, and this is what the clever people say we should do, let's do MRI scans. To exclude patients who have undergone neoadjuvant chemotherapy, yes, that makes perfect sense. And why is this keeping on coming up? Because again, we don't know how much viable tissue is there, what the extent of the tissue is there, so yes, that makes perfect sense. And obviously we need histopathological diagnosis before we do anything in terms of invasive, even RFA, because we need the receptors, because immediately after RFA, the receptors can change. So the technique is quite simple. You put, like I said, percutaneously, a needle is put in, and then it creates heat, and you have an ablation across a volume depending on the shape that you've done it. If you've got an irregular shape or a larger volume, you can use another needle and then alternate the currents between the two, so that way the field is bigger, and so your target volume becomes bigger. Or you also have a new technique which uses cooled saline at the tip of the needle. So you cool that area, that way you reduce charring or burn tissue, and therefore you reduce the bioimpedance, and that way the current can go peripherally for a greater distance. Now, as we know, the breast is not a single fatty tissue or a single glandular tissue. There's a mix. You have bilines A, B, C, D. So depending on what kind of breast you have, you will have bioimpedance that needs to be adjusted. So fatty tissue will have greater resistance. If you have dense tissue, it'll have less resistance. So let's look at the non-surgical definitive treatments for operable breast cancers. And if you look, these are all the options. So you've got radiofrequency ablation, then you've got HIFU, which is high frequency ultrasound, you've got cryoablation, micro, and laser. But what is important is all these patients underwent whatever they did for local ablation of the tumor, and then they had the tumor excised. And the follow-up, median follow-up is only 16 months, so it's not long, but that's what we've got. And if you look at complete necrosis, you've got it here. So for RFA, it's these 3 columns that count. But it's this column that makes the most sense, because when the tumor was then excised surgically, they found that 92% of them had complete necrosis. But these patients also underwent systemic chemotherapy, also underwent hormonal therapy, and surgery. Patients who had only surgery and radiotherapy, it was 42%. Surgery alone, 61%. That doesn't make sense, but that's the data I'm reporting. But it could be to do with the volume of the tumor that was they tried to ablate, because I'll show you later that it's a function of the volume. Now, patients who had radiofrequency ablation without definite surgical ablation. So if you look at all these studies, this is the various things that they used, the cool tip to allow for greater dissemination, ultrasound guided, most of them. Now, if you look at the follow-up and outcomes, this is 18 months follow-up, no recurrence. Median follow-up is about 29 months. They had 1 local recurrence. Median follow-up 15 months, no recurrence. And this is 52 patients, 5 patients. This is a small series, but 52 patients, this one counts. 15 months, no recurrence. And then again, they get smaller series, but then this one is 30 months, and they've got no recurrence at 30 months, 17 months. So it's not a great follow-up, but it does work. So let's see which patients can actually benefit. So if you look at all these responses here, so this is patients who, hang on for a second. Okay. Again, patients who had a radiofrequency ablation and ultrasound, and then they had complete immediate surgical excision. Complete ablation, 96%, 100%, 100%, 93%, 100%. So let's look at these, the 100% here. They're tumors less than 2 centimeters. This one, 4 centimeters, but then it falls down to 76%. This one again, less than 3 centimeters, but 76%. So if you use small tumors, you seem to get a better response. Again, if you look at these patients who had delayed surgery, so you did the radiofrequency ablation, you waited for some time, and then you went in and did the operation after a few months. So the delay is there, 1 to 3 weeks, 1 to 2 weeks, 4 weeks, 1 to 2 months. So if you go in after 1 to 2 months, you get 100% cell death. And again, this is small tumors. So there is probably a reaction that happens, or there's a tissue reaction that happens, and that causes more cell death at a later time, because if you look at the 1 to 3 weeks, it's between 86 and 90%. So it's not great. You have 10% where you'd say it was not completely killed or false negative. So this is a retrospective study again on radiofrequency ablation, but that number is healthy. That's why I chose this study, 386, 10 institutions. So it's pooled data, followed up every 6 to 12 months. And this was looking at the feasibility of radiofrequency. And they said, yes, it's safe, ipsilateral breast tumor. And they made the same conclusion that I told you about smaller tumors. And I would say you would also add good biology, because you want to give some systemic treatment after that. So you're not going to give the triple negative treatments, because like I said, post-neoadjuvant, you're not going to use this. You're going to use this in good biology tumors, luminal A's, where you can give them radiofrequency ablation, radiotherapy, and then some hormonal treatment. But this 390 patients, what they found was complications, because that's what you want to know. What are the complications? So out of all the patients, 9 patients had pain. Some of them had skin burn, so that means the tumor is superficial and we need to be careful. And nipple retraction was in 7 patients. But the local recurrence rates, if you choose a tumor less than 1 centimeter, it's 97%. Again, this is the median follow-up is not very long, but that's what we've got. If you choose between 1 and 2 centimeters, it's 94%, and it's more than 2 centimeters, it drops. So you need to choose your tumors well, you need to choose your biology well, and how does it look once you've done an MRI before radiofrequency ablation, and this is the ablated field. So you get like a ring artifact that's around it, but then if you look within it, there is no enhancement. Oh God, sorry. So this is a CT scan which shows tumor, post-ablation, and this is residual tumor even after ablation. So these tumors will need to be excised, or at least biopsy, prove that they're viable tissue and then excise them. Side effects of another meta-analysis: skin complications, 3.2%, breast inflammation, 2%, obviously you see because of the heat, nipple retraction, pneumothorax, because the needle goes straight through the tumor into the thorax. You really have to be skilled to do that under ultrasound scan. You really want to harm the patient to do that. And then you've got chest and muscle burns. So the results were 399 patients, 401 lesions, 99% achieved good technical success. So we're talking about the technique and not the results. Most of them in this study had it under general anesthesia. A small percentage, 15%, had it under local anesthesia. And 94% of this 15% tolerated the pain well. Majority of the patients underwent surgical excision after the ablation, and some did not. So incomplete ablation was achieved in 96% of the 65% that underwent surgery. Overall, 2% had complications, so it's not high, no recurrence, median follow-up of 27.29 months, so it's almost coming up to 3 years, not 3 years. Whether or not they underwent surgery or they didn't have surgery. So see that 65% had surgery, but 34% didn't have surgery. And at 27 months, even those 34% didn't have a recurrence. So the conclusion was the same that we drew when we saw the data. Results show that radiofrequency ablation for breast cancer smaller than 2 centimeters is safe and effective. However, prospective studies are required, which is a caveat for everything. So in conclusion, I think we can safe to say that if you have a clinically N0 axilla, this procedure seems to be technically feasible, and that's been proven. The side effects are very low. The complication profile is very low. Tumors less than 2 centimeters with nice even edges or nice rounded borders rather than diffuse tumors, not extensive DCIS. And like I said, good biology, so you can follow it up with some tamoxifen or letrozole and make sure that that also reduces the risk of local relapse. You have to administer, like we saw in that paper, we did surgery, chemotherapy, and radiotherapy. So you have to do adjuvant treatments as you would normally. All RFA does is replace surgery. And it has a definite role in palliation of mets that are painful. So thank you for your attention.
Thanks for good presentation. I'd like to thank you again. I think it's a confusion topic for surgeons. There are lots of questions, I think. Is there any question?
I don't do it, so don't ask any difficult questions.
Mr. Koshto?
Yes. Potentially, yes, but if you look at all the indications, they say no because of the patchy response. So if you have a Swiss cheese response to let's say, to the chemotherapy, and then you do radiofrequency ablation, you don't know the size of the tumor bed. So I think what these authors are saying is that if you can define the tumor bed accurately, up to 2 centimeters, then you can get a good response. But if it's a bigger tumor bed, and we don't know whether the response is patchy, so if you get a concentric response, it's great. But if you get a patchy response, which is you can see with neoadjuvant chemotherapy, then I don't think this is a technique that people say is safe.
Say no.
Yes, they didn't tell us the axillary, but obviously they're saying no local relapse. That means they're talking only about the breast. So clinically, all these studies were N0. Most of them didn't have core biopsies of the axilla. So they were talking about control in the breast. And obviously, most of these patients, I don't think the healthy volunteers would have volunteered to do this because they would probably do surgery. So I think this was done in patients who said, I don't want to have.
What's going on?
Sorry, that wasn't me. But yeah, so I think patients who probably decline surgery, because all of us have these patients who say, no, I don't want to have anything done. The old frail people, probably they did that in this because, if it's a randomized trial, which they don't have one, then it's difficult to recruit patients to say, this is the standard of care, but let's do radiofrequency ablation because I'm trying this as an experiment. So we have to take this with a bit of pinch of salt because they haven't given detail about the patient profile and why did they opt for radiofrequency ablation. Because I had the same question, what did they do for the axilla? That's why I avoided it, but you caught me.
Thank you for your good presentation. I understand that we will use this technique only maybe with serious comorbid patients. Routinely, we don't think to use.
So I think if you have a tumor less than 2 centimeters, you can even excise that tumor under local anesthesia or regional blocks. So I would say that patients who don't even need radiotherapy afterwards, you ablate the tumor, give them some treatment and systemic treatment, and then hope for the best. And that's why you see the publications are just dropping off, because they've explored enough, and now they think it's like a toy. When you have a new toy, you play with it, and then you realize that there's no function for this toy, so you give it up.
There's another question.
Oh, great.
Thyroid and breast, you know that the thyroid tirades for the breast birats, and for the thyroid, after the ablation of thyroid, the new classification, new update is published now, the tirades PT, post-treatment. Because of the, after the ablation imaging modality, is very challenging because the irregular margin and hypoic appearance, something like that.
Yeah.
And after the ablation procedure for the breast cancer, how do you follow the patient?
So most of these people have been using ultrasound scan.
Yeah.
That's why I showed you the two pictures which I found, one of MRI scan and one of CT scans, where they can show residual tumor, and there's tracer uptake in both on the CT, but there was none on the MRI, and there was this big artifact. So I would follow up with ultrasound scan. Yeah. The problem is you don't have any strong indications. So outside a clinical trial, if I had to use this, I would be quite skeptical. I don't know what you guys think, but if your surgeons are happy, then you should start a randomized trial and see patients, let's say over the age of, yesterday we had this debate about what's old and what's young, so I'm not going to say an age. Over a certain age, X, you randomize them to have surgery and systemic treatment, or so ER positive tumors, luminal surgery and systemic treatment versus RFA and systemic treatment. And that's the way to go, I think, in the future. This to be accepted as a treatment, you have to have a control arm and then prove that the experimental arm is at least not inferior to the control arm. But your numbers, because correct me if I'm wrong, your local relapses are so low, so your numbers to treat would be quite high.
Yeah, well, I have I think it's more appropriate after my talk as a summation of all these things. Yeah, yeah.
Thank you so much.
I think there is no question. Thanks for good presentation. Mr. Ash said that 2 centimeter tumors is suitable under 2 centimeters for RF. There is a good conversation again. Large volume excision. Mr. Andres Karatasanis from Sweden will talk about this topic.
Once again, thank you very much for having us here. Thank you for the honor of the invitation. And thank you for the very particular honor of giving a talk that is something else than magnetic techniques, oncoplastic surgery, and neoadjuvant therapy, because this is what I have been doing the last 4 or 5 years. But this was very stimulating and challenging. And what I'm going to do today is that I'm going to walk you through the way I think. And for people that know me like Ash, they know that I do not really have different opinions about things. I have one single opinion, and the single opinion I have is, what does the data say? So I will walk you through the data, regardless of what I would have wanted, and then I can tell you what I want. Okay, these are my disclosures. Let's take it from the beginning. So the advances of obtaining more material for preoperative pathological confirmation led to the development of vacuum-assisted biopsies And what is that? More or less, it is a large bore needle with vacuum that allows us to go into the lesion or in the area of the lesion, especially in non-mass-forming lesions such as microcalcification, and under stereotactic or ultrasonographic guidance to perform excision of samples with the help of vacuum. What is the benefit? The benefit is that a larger needle will allow for larger samples obtained. To give you an estimate of the size difference, one vacuum-assisted biopsy with a 7-gauge needle will harvest 13 times, 13 times the volume of a core biopsy of 14 gauge. So, and we've got some other things like the possibility of clipping the biopsy area and some more daring and braver radiologists or surgeons that deal with that can inject sclerotic medication or whatever. But this is also something that's made on individualized basis. And why do we need that? So the reason I changed this presentation very recently is that this is a big randomized controlled trial, a phase 3 controlled trial, published in the International Journal of Surgery just on Wednesday. And what they did is that they looked into the diagnostic role of vacuum-assisted biopsy versus core biopsy. And what they saw is that, well, you do not really need it for each and every lesion, but however, high-risk lesions had a relevant clinical but not statistically significant difference, and in the case of DCIS, accuracy and the malignancy under-detection rate were statistically significantly different. So the authors went further and defined groups where you should be doing that. So is it for every case? Because in this analysis, you see that the odds ratio remains statistically significant for vacuum-assisted biopsy against core biopsy. But actually, and if we are to be clinically relevant, what we saw here is that the maximum benefit of this policy for diagnostic purposes is exerted for microcalcifications, lesions of heterogeneous echogenicity, BIRATS 4 and 5 lesions, and they saw that for B3 lesions, especially atypical ductal hyperplasia, there was significantly lower underestimation rate. This suggests that vacuum-assisted biopsy can be a problem solver when we have to deal with these situations, so that we can more accurately estimate what the lesion is, so that we can make decisions. And the safety profile, this is what I found interesting, because I remember that back in the day that we were doing the transition from fine needle aspiration to core biopsy, the concerns were the complications and the bleeding and things like that. And now we're talking about something that's much more invasive compared to the standard core needle biopsy. It was completely comparable. Going a little further, we accommodated a very nice systematic review and meta-analysis at the EJSO last year from the group from Ireland, where we saw what I had suspected. It is a low level of evidence because of high heterogeneity and studies that were not performed with the best of premises methodologically, but vacuum-assisted biopsy in the setting of these B3 lesions that are a headache for the clinician seems to be able to give us higher diagnostic accuracy if compared to the previous methods that we were using. So from that, the next logical step, the next frontier would be, if I can biopsy it and I just need to push on the pedal one more time to suck it all out, why shouldn't I do it? And the principle or the intention is the excision of the entire lesion, but we are talking about piecemeal excision. So you cannot take the lesion as it is with vacuum-assisted excision. And that may allow for clear radiological margins. However, it does not allow for certainty with regards to the pathological margins, which is a very crucial parameter when we are discussing DCIS or invasive breast cancer. And we will come to that in a bit. So I did the PubMed time trend thing before Ash. I just want to tell you. Okay, so And I did searches both for vacuum-assisted excision breast and vacuum-assisted breast DCIS and vacuum-assisted excision breast cancer, but the subcategories were not convincing. And you see that this has been, since approximately the middle of the 2000s, has been a field of interest, and we have waves where the interest comes up and comes down, and now we seem to go a little bit down. I mean, we're early in 2023, but still, this suggests that while this is something we feel is interesting, there have not been the efforts that we would expect to get solid data. So the study that we need has not come yet. And from a quick review of the trial registries, I have not seen that something very big and shaking will come anytime soon. So the data is like what we unfortunately do very usually when we want to interpret them. We interpret them as we want to, like the bed of Procrustes. So from the ancient Greek mythology, Procrustes was one of the three bandits that Theseus met on his way back to Athens, and he had a bed, and he put his victims in the bed, and the victims that were taller than the bed he would chop head and feet, and the others he would stretch. So we kind of have the tendency to interpret the data, regardless of their limitations, to the way that we want them to be. It's a little bit of a wishful thinking. Anyway, but if we come to see what the practice is, the clearest recommendations that you will find out there nowadays is this steering document from the NICE guidelines. Ash knows it, I'm certain of it. And what does this tell us? Let's walk through that. So a woman attends assessment by be a core biopsy or vacuum assessment directly, depending on the nature of the lesion. The pathology report comes back with a B3 lesion of uncertain malignant potential. The multidisciplinary team will have to make a decision to recommend either vacuum-assisted excision or open surgical biopsy. But if you do not get a clear answer, malignant, benign, you cannot make the definitive recommendations. So whilst assisted excision is something to prefer if you have a lesion of uncertain potential, you cannot say that excisional surgery is wrong, because if you do not have these possibilities, you would have to go there first anyway. And mind you, what is very clear in this recommendation is that this is a patient pathway with second-line vacuum-assisted excision after B3 outcome. So this is not something that we will consider that we will go there first. For example, if you have an area of microcalcifications that's 2 centimeters, performing upfront vacuum-assisted excision without knowing what it is would be wrong. But still we are enthusiastic, and so we are aiming beyond this frontier, despite that it is very clear that we're not done with it yet. We do not know how to deal with vacuum-assisted excision in our everyday practice, and there is not enough evidence to suggest that it is a method that will give us a clear-cut solution in any case, because this is what you need in order to be able to implement something in routine practice, right? But there are visionaries, or more, or brave anyway, are discussing vacuum-assisted excision or large volume biopsy, or large volume excision as we call it, in the setting of breast cancer, pre-invasive and invasive. But in reality, current data is missing, and what is actually happening is that practice outruns and precedes the data, so the data we get is the result of practice that we did just because we decided to do so, which is something that will always affect our decisions on the implementation of the technique, because the level of evidence that is obtained this way is very low. And we will land in a situation similar to what Ash showed in his talk about the radiofrequency ablation, that there are studies out there that do not cut the deal. We cannot make definitive decisions. So we need to think otherwise. And we have to think what is out there. So something of an irony. This is not my topic, but you will understand my case. So vacuum-assisted biopsies with piecemeal excisions in a completely different setting. So this is where we have some type of data. So post-neoadjuvant chemotherapy, what they did is that they took extensive vacuum-assisted biopsies of the area, and if they had no remaining disease, they went and did boost radiotherapy and whole breast radiotherapy and did whatever they did, and this looks fine. But again, take this with a pinch of salt, because this is a study of 58 patients, which became 54, and out of these, we did it in 27, and so on and so on. So, I mean, it is they did it in 1/3 of the people that are in the room. So we shouldn't be very enthusiastic about that. This just tells us that this is perhaps a potential for the future that we need to open our minds to. But in the upfront setting, so in the setting of replacing surgery with vacuum-assisted excisions, we are simply not there yet. What are the efforts ongoing? So there is this single-arm study from the Netherlands that is ongoing. It is from Rotterdam, the MiniVAP study, where vacuum-assisted excision of the lesion will be performed if you have histologically proven non-lobular invasive breast carcinoma that is less than 15 millimeters, and they will have to have had a preoperative MRI performed to know what's happening. So the idea is that the patient comes to the radiologist performs vacuum-assisted excision, they will leave a clip the way they can leave a clip there, and this will be succeeded by surgery after 3 weeks, so that we can see if the lesion was actually removed accurately. And the primary endpoint here is the incidence of successful complete tumor excision by the vacuum-assisted biopsy system, defined as having no tumor foci beyond 1 centimeter from the edge of the VAB cavity in the surgical re-excision specimen. They have a ton of secondary endpoints, and I do not think that 170 patients will allow for adequate analysis, but this is a mystery to solve in the future. And on the other hand, has anybody here done such a procedure? Because I have done 2, and they were both by mistake. It was the same radiologist that went, and he did that, and it was an invasive cancer, and we had to take the patient to surgery. It is awful. You operate for, so if the index lesion was 10 millimeters, you operate for something that clinically feels like 4 centimeters from the fat necrosis and the bleeding, and you perform a quadrantectomy for something that would have been, you know. Anyway, so what I'm saying is not that we should not be doing it. It is that there are practical challenges to the conduct of the trial that have to be met. And then there is another study, and this gives me the opportunity to discuss a little bit about the concept of de-escalation, the way I see it, the small trial from the United Kingdom. So this is a phase 3 RCT with a target accrual of 800 patients. With an allocation ratio of 2:1, so 2 patients will undergo the experimental, will go in the experimental arm and 1 in the control arm. And what we want here is patients older than 47-year-olds with screening detected cancer, non-lobular, grade 1, strong ERPR positive, HER2 negative, and small in size, less than 15 millimeters in maximum diameter. And in an update of the trial that Stuart McIntosh had as a poster in ASCO last year, they had 90 patients, and I think that this started running 2018, I think, yeah. So we have a way to go for that. But what I want to lift here is that we are discussing about the potential of not operating, but sucking out the small luminal A breast cancers that are clinically and radiologically node negative. But I see a very big pitfall here, because we are discussing on alternative methods to surgery as means of de-escalation. But the de-escalation, the recipient of treatments is the patient. So the patient will get the whole package regardless of what we as clinicians do. So I just need to point out this. Patients with complete radiological excision will undergo radiotherapy and endocrine therapy mandated. What does this mean? This means that a large bulk of these patients, and Ash, correct me if I'm wrong, would be appropriate for the PRIME2 trial. Older than 65, 5 with small tumors. The update of the PRIME2 trials showed that ER positivity and strength of ER positivity correlates with the outcomes as well. So what are we telling somebody? Are we telling them that we will be doing that so as to avoid surgery, but if we do that, we have no chance of avoiding radiotherapy, which you could have avoided if we had done surgery? So this is something that I feel we need to take seriously into account, and this is something that applies also in the case of radiofrequency and cryofrequency ablation. So it is a de-escalation of a local treatment, but the trade-off may land in that we have to treat, I mean, we know there is sufficient data in the literature that a luminal A breast cancer that's T1A or T1B that is node negative may not even benefit from systemic therapy at all. So you have curative surgery, and you do not expose the patient for any of the other risks that we as surgeons and some gynecologists do not know how to deal with. Because we had this discussion yesterday. You cannot tell somebody that is suffering from their tamoxifen treatment, you should be happy you're alive. Because they're alive and they have to live with something that you did to them. It's a little bit of a conundrum. Anyway, what are the challenges for this final frontier? I think that there may be a way to go, but I do not see that the evidence suggests that vacuum-assisted excision technically, if we still wish for margin assessment and verification that we have removed the entire lesion, is the way to go. There were some efforts, and the most common was this BLESS, the system that removed the intact lesion under stereographic guidance in the mammotome, and they were burning it with radiofrequency ablation, but that was also given up because the re-excision or the involved margin rate was very high, unacceptably high, and highly variant from study to study. But this has to do with the fact that the literature was a collection of studies like those that Ash showed. Small institutional series, feasibility series, another feasibility series. So it's like getting 100 anecdotes. Some of them may be very funny, but 100 anecdotes, 100 case reports does not equal to a trial of 100 patients. And we will not get any evidence if we don't look at it in another way. So we have to start wondering, is currently available technology adequate or appropriate for the purpose that we wanted to serve? And is this intended de-escalation of surgery, as I said, perhaps a masked escalation of overall treatment? This is just food for thought. With regards to the first, I am aware of several newer systems that are currently being developed, and clinical research will start with them in a few months' time, that think in a completely different manner. What we need to see is if they will actually work. So the conclusion, large volume excisions are promising for the future. Currently, data is lacking to support its use outside the clinical trial or as an exception to the rule. So if you have a multimorbid patient that cannot undergo any type of surgery, I mean, we had this discussion with Yazan a couple of weeks ago where he had a woman that was in very bad shape and with terrible scoliosis, and so she cannot lie on the bed. Okay, fine, then you do it, but there is a very big distance between doing it for one patient where you want local control and some kind of palliation to saying this is how we'll be doing things from now on, right? We need refinement of the available techniques. We need development of appropriate technology, and we still need to see the patient as a whole and understand as surgeons that the role and the dimension of surgery for the patients are crucial. And whilst the primary goal is that we need to remove the cancer, it is not the only purpose of doing surgery in these patients. Most of the times there are severe and very, very important quality of life issues, patient expectations and goals that need to be met. So we just don't do it. And the reason that we have to think about that is that we would otherwise have not been curious with, for example, oncoplastic surgery. We would be doing what we were doing so many years ago. And these were my 5 cents on that, and thank you for your attention.
Thanks for a good presentation. First of all, I would like to ask a question of small trail schema. Do you know what about the cut of the patients' years? Cutoff year is age is 47.
Yes.
47. For 47.
Over 47.
Over 47. Over
Over
47.
So what I am guessing, because if we had done this study in Sweden, we would have said 39 perhaps. And this I am guessing because I read the entire protocol, all 89 pages of that. There is no clear explanation. My interpretation on that has to do probably with the fact that currently the UK screens regularly from 50 to 69, and some patients that are of higher risk for more dense breasts may get a referral mammogram some years before. So they hope to catch these ones. Probably they were afraid to leave the 45 to 47 in the trial, and they went for that.
Thank.
Now, in certain areas in the UK, you can get screening for 47.
Yeah.
It used to start from 50 to 70, but now it's 47 to 75.
So I said 39 because in Sweden we offer screening from the age of 40 to 74. So, the higher risk patients, you tell them, get a mammogram or get a baseline imaging from age 35 sometimes. And you would be afraid to do the 35 to 30. It's a little bit of kind of a Solomonic solution, kind of.
But it'll be interesting to see when the data comes out how many of these are actually post-menopause. You find most of the patients, clinicians will talk about. Most of the patients will be comfortable with 60, post-menopause, human age, and how 40, pre-menopause.
This is a very important point because a study, a clinical trial, and the results that are can be derived from that is not the selection criteria. It is actually the population that was enrolled and participated in the trial. So, and this is why I made this point. My gut feeling as a clinician as well is that we will, despite this being a randomized controlled trial, I am suspecting that there will be a kind of unconscious selection bias with regards to that, both on the patient side and the clinician side. So we will be landing with results that will suggest that most patients that will have been treated in this trial are patients that would otherwise could have skipped radiotherapy. And they will get it just because we did not do surgery to do vacuum-assisted excision. That's the case.
Thank you. You know that we are giving our meeting from the YouTube channel. There is a question from the YouTube channel. Maybe Ash, the question is for you. Sorry. Diana Artena, how are these studies? Yeah, it's a good question. Okay. How are these studies who actually used immediate or delayed surgery proof that radiofrequency ablation is therapeutic? Is there any data comparing radiofrequency ablation alone versus radiofrequency ablation plus surgery?
No, so all the studies that I showed either had an immediate excision of the tumor bed or had a delayed excision of the tumor bed. So that's what I said at the end, that you can't trust this data because this is anecdotal, institutional series, small series. The largest one we had was between 40 and 50 patients. So as Andreas said, unless you have a head-to-head comparison where you have randomized patients, because you need an equal population cohort. Yeah. And the only way you can get an equal population cohort without any biases are if you randomize. So there is no study that is randomized. So you probably it'll be difficult to get patients to enroll in this because you have to say this is standard of care and this is what we are planning to do. Maybe patients who don't want surgery will enroll, but it'll be a difficult trial to recruit.
Thank you. This is the evidence of our meeting is going on YouTube channel, this
Great.
question.
And thank you, Diana, for listening.
Is there any question?
I think that there is a question.
Yeah.
I just, so we worked with Medtronic for the intact device. And even before they could study the data for clean margins on it, there was issues with it being done under local anesthesia and excessive bleeding and extreme discomfort to the patients. So if there is a device that is being worked on, maybe those issues need to be addressed even before you can focus on the
Exactly,
cancer.
exactly.
Yes.
This is exactly my my point. We have to. I personally do not understand the notion that we are winning anything by doing something that will be remembered as a torture. For the that's another thing. And another thing that I will have to say very openly as a surgeon with regards to these techniques is that if you ask for my personal opinion, I would like this to happen, because you all very well know, and I think that there are people in the room that are more experienced than myself, but I've done my share of things that, and I think that you will agree, the most difficult surgeries, for my part, is not the case where you will have to do something elaborate and fancy, because you know a good therapeutic mammoplasty or a perforator flap reconstruction or an implant-based reconstruction you can either do or you cannot do. So there is some selection in that. So what comes to your hands, it is a prerequisite that you can do that. But the difficult surgeries, or the surgeries that are suboptimal, are actually these surgeries that we do for the 3 to 9 millimeter lesions or calc groups, where you remove 4 or 5 times the volume that you would need to remove, and you land in over-treating, compromising functional and aesthetic outcomes, potentially increasing complication rates and things like that. So I would be very happy if I knew that there was another way out of these situations. And I mean, don't get me wrong, the vacuum-assisted excision thing is something that may sporadically work, but we do not systematically know it. I mean, I had a patient, and I'm sure that everybody has stories to share. I had this lady with a 3 millimeter screening detected microcalcification group, and they did vacuum-assisted biopsy, and everything was removed, and that was a DCIS grade 1. And as it happens sometimes, the clip kicked back, and it sits a couple of centimeters. So what do I do there? Do I need to operate for margins for something that... So we told her that this is how it goes. Formally, we need to discuss surgery with you. I don't have any good idea of how representative the surgery will be or what it's going to add to your outcomes. The other thing is that since we would not get radiotherapy or any systemic treatment for that anyway, is that we'll wait and see. Mark.
Yeah, Andreas, so thank you for the excellent talk. I like your idea that we can cover these little or these small tumors via a vacuum biopsy system, but I'm asking myself, is this really the future? Because it depends on the tissue, it depends on the fat tissue, fibrotic tissue, it depends on, do I have a hole afterwards? What happens to the hole due to the fact that all these patients undergo radiation? So I would prefer, from my point of view right now, to put an intermammary flap in the hole so that I'm safe, that the cosmetic result is nice. And so we discussed yesterday about vacuum biopsy systems we used in the axilla for replacing sentinel biopsy, and I worked for years with the mammotome, handheld mammotome, and we were really struggling about these bleedings, and it was invisible what you tried to remove. And then there was this Abbey system, I remember, so of 2 centimeters. So we left this system due to bleeding and due to worse cosmetic outcomes. So I think we have to evaluate that in, let's say, in a prospective, proper way to find out where are the obstacles and where are the failures.
Exactly. These are my thoughts exactly. And I'm happy because you touched on something that has to do also with my thoughts as a surgeon. And this is something that reflects my way of thinking. I'm not suggesting that I'm right or wrong here, but I think that we surgeons are very dependent on the idea that we have done a good job and that we have adequate control. When you do something like that, I mean, a breast surgeon can incise through, remove, reshape, and fix things the way you know how to do and you feel safe with, and you know how your outcome is going to look like, right? This is something where we lived too much to chance. And this is why we have to be open to new ideas, but they have to be very, very meticulously and very, very robustly evaluated without making any compromises. I mean, when I was a resident, the blessed thing had struck, and it was a big thing because there were people saying that you can remove the cancer this way, but you cannot. So here we are, only 5 years later. No. but it's not like that. So this is a blink to the future, but it is not the future. It is a potential future, and it may be the reality if we lay our focus in producing high-level data around it.
So just correct me if I'm wrong, because when you do it this way, you can't comment on margins. So what you're effectively achieving is a reduction of the tumor burden. That's all you're achieving.
Exactly.
And then you're killing everything else off with radiation therapy.
Exactly.
So
and this is, I mean, I would be happy if somebody comes with a vacuum-assisted biopsy that has fancy buttons, or is faster, or removes more tissue, or has no bleeding, but they cannot tell me anything about margins. I'm sorry, but I'm not interested. In the sense that when we discuss at the MDM, I mean, you've got focally positive margins, and this is not acceptable worldwide, with the exception of the Netherlands, where they accept margins involved up to 4 millimeters, and then instead you grill the breast with radiotherapy and boost, and perhaps you will give a boost to the sister to be on the safe side. I mean, this is over-treatment, and it doesn't sound very, very reasonable to say that to avoid surgery, you will escalate everything else.
Is there any question? Thanks for Andreas. There is a good discussion for these interesting topics. Yeah.
session with my colleagues, Dr. Gazioğlu and Dr. Mutlu. I hope, Doctor, excuse me, his wife's name is Mutlu. I wanted to test the attention of the audience. I will be a good politician, I think, in the future, because most probably breast surgery is going to be finished or not. I think I am the oldest in the session, and if I gonna be the resident at this moment, definitely I am not going to select the breast surgery because the future is not proper. After this session, maybe we will lose our job. But I don't think so. Breast surgery will go on. We will defend our field, but that's true. We are de-escalating every day, not every month. And our de-escalation is going to be occupied by our colleagues, radiotherapy and medical oncology. Don't let them to feel free. We will defend our rights because surgery is a treatment modality for the breast cancer. Now I will let my friends to talk about the session.
Come on, my friends. Surgeons are so smart. You don't know that. They will never leave their field to anyone.
We will have always second opinions for the treatment.
Okay. Our first speaker, Dr. Ash, we will talk about omitting surgery after neoadjuvant chemotherapy. It's a debate form, so debate. It's a debate. Okay.
Debate is over? Yeah. Atakan has won. Let's stop. Okay, again, can't see my slides again. Yeah, you see? Any tricks? Okay, great. So again, thanks to all of you. I'm here. I love coming to Turkey. It's great. First time in Kocaeli, enjoying it. So I received a phone call from this man. You know, it's not your new president. It's the new rector. And he told me. And then he told me this.
Your mission, should you choose to accept it?
So he said, your mission, should you choose to accept it,
Should you choose to accept it?
is to debate on no surgery after NACT. And I'm for. So I'm saying, as a surgeon, I'm saying we shouldn't do more surgery, which is actually against all of you, but let's see. So Atakan is a good friend. We know him for years. But then when I realized whom I'm debating, I had these problems. So I was thinking of all this is going to happen during this debate, yeah? So you need to be prepared for all this. And that's Atakan on his new motorcycle, coming to get me. And this is going to happen in the end. It's mission impossible. Okay, great. So these are my disclosures. Now we can get to the real serious stuff. So as we said, the current trend in breast surgery is de-escalation. So you see what we're trying to do is the oncologists are launching all these missiles and we're saying, no, don't do that. We will de-escalate surgery. But things are changing. So always is never always the right answer in oncology, and never is never the right answer either. So we can see that we've come from way back of radical mastectomies to 2019, At St. Gallen's, when we said sentinel node biopsy can replace ALND, and then in 2021, there was a multivariate analysis that said vacuum biopsies, or clever, intelligent vacuum biopsies, can diagnose complete pathological response. And then in ASCO 2021, we said surgery can replace ALND for post-chemotherapy. So what happens in 2023? In 2023, we may come up with today, we won't do surgery after neoadjuvant chemotherapy. Let's see. So long live the king. You know we have a new king after Brexit. So long live the king. But I'm talking about the other king. So in the world of surgical oncology, biology, tumor biology is the king. Selection of patients is the queen. Technical maneuvers are just the prince and princesses. So the operations that we do are prince and princesses. And occasionally, the prince and princesses think, let's overthrow the king and become king and queen ourselves. But what happens to them? They most always fail. So, oh, you want to take a picture of that thing? You can take one. So this was Blake Cody, and he thought of this in 1996. We're talking about precision medicine in 2023. In 1996, Blake Cody said that precision medicine is here to stay. And this is borne out by the fact that if you look at 53 randomized controlled trials with a lot of patients, 86,000 patients, which were between 1990 and 2011, what do they show? The proportion of loco-regional relapses has decreased from 30% to 15%. That means it is halved. And it is not because of what we call the blade or the sword. There is no interaction between the surgery, that means mastectomy or lumpectomy, and even adjuvant radiotherapy or menopausal status. It is all down to systemic treatment. So better systemic treatments have played a role in local control. And you can see this here. In gray is patients, all the patients. In orange are the patients which are hormone receptor negative, and in green, they're hormone receptor positive. But if you look at the HER2 positive, which is orange color, you get a lot of response in patients following neoadjuvant chemotherapy. And if you look at the last column there, it's almost 77%. And if you look at pembrolizumab, there is almost a 13% difference between patients who received pembrolizumab and didn't receive pembrolizumab for complete pathological response. So systemic treatments are making a difference, and they're giving us better PAT-CR. So tumor biology is showing that it is the king. The clever people say, yes, for HER2 positives, let's do neoadjuvant chemotherapy. So this is high level and strong level of evidence to base the fact that, yes, neoadjuvant chemotherapy is here to stay. And this is why, because you look at this tumor, it's a massive footprint. In the olden days, she had a mastectomy. And if you look at the picture below, that's a complete radiological and complete pathological response. But the clever people in St. Gallen's were asked this question, and they were obviously on Atakan's side. He had paid them. So they said, no, you can't omit surgery completely. What you have to do is do surgery after complete pathological response. So 86%, which is the high majority of the St. Gallen's Consensus Conference, thought that surgery is definitely required. Let's see this conversation, yeah? This is a young, handsome surgeon and lovely patient. So the patient comes to the room, and this is the conversation. Your imaging shows an excellent response to chemotherapy. Great, all those terrible side effects I endured were worth it. You say, yes, but you still need surgery. And she goes, what? I still need surgery? For what? Is there a way to avoid it? So let's see, is there a way to avoid it? Let's try and make mission impossible mission possible, okay? Now the problem we've got with neoadjuvant chemotherapy, as we discussed in the last presentation, is the way it responds. You don't always get a concentric response, you get a patchy response. So if you look at this tumor here, you have these few tumor cells, and the rest of it is just fibrosis. Now this tumor cell is low volume disease, but if you look at it in whole entirety, it's a false negative. So it's not a complete pathological response. So this is easier if you have this, but if you have this, your decisions become harder. And this is why. Because response, if you biopsy that, there if you put a vacuum biopsy, your complete pathological response. You excise the specimen, and it's not a complete pathological response. But is that volume of disease enough to make us worry? Let's see. So what we are proposing is a new normal. The new normal is the patient has systemic treatment. If they have a complete clinical or radiological response, proven on vacuum biopsy, they don't go on to have any surgery, but they'll go on to complete their systemic treatment, radiotherapy, and any immunotherapy if it's required. That's what we are proposing. So this is a review article on studies omitting surgery after neoadjuvant chemotherapy in breast cancer. And if you look at that, this is the diagnosis. So how do we bring down the false negative? Because this is all on the fact that we cannot accurately predict which patients before the operation have a complete pathological response. That's the conundrum we have at the moment. And if you look at all these studies, especially Heil has done a lot of this work, mammographically guided vacuum-assisted biopsies, 11 gauge, 100% negative predictive value, false negative rate, 0. But if you use ultrasound scan, the false negative rate goes up. Now, if you go down all these, there's a 398, the false negative rate is 17.8, but if there's no residual lesion found, you can bring that down to 6%. So there are ways and criteria that if you use intelligently, you can start making an algorithm of which patients you would try and do the surgery in, prevent surgery, in which patients you need surgery. And the list continues. So the false negative rate goes anywhere between 3.2%, which is a pooled analysis done by Marios in the Royal Marsden, where he's pulled data from 3 studies, and I'll show you that slide later on, but he's brought it down to 3.2%. So the false negative rate is 3.2%, not the local recurrence rate. So you have to differentiate between what we are saying here. The false negative rate is 3.2%. The local recurrence rate will be the same. Remember when Holland did all his clever things about dissecting the specimens, when you do a wide local excision, if at the same time you do a mastectomy, in between 40 to 50% of patients you'll find more disease there. But this is a different kettle of fish because these patients have received chemotherapy, and post-chemotherapy they have residual disease. So the argument is that this disease is aggressive, we need to deal with it. And these are patients who had only radiotherapy instead of surgery. Now if you look at that column there, which is what Atakan will show you, it's horrible. You know, if you look at that column, it's 31% versus 17%. You've got 21% versus 10%, so it's a doubling of the local relapse rate. Now, local relapse is important, but when you treat patients and you give them all these great chemotherapies and all the toxic drugs, what are you trying to improve? You're trying to improve their overall survival. If you look at that column there, overall survival versus disease-free survival, there's no difference. So although they have a higher local relapse rate in patients who have a false negative, if you look at that disease-free survival there, 5 years, this is radiotherapy versus no radiotherapy versus surgery, it's actually better. So surgeons are doing something, and that could be because of the inflammatory response. And here, if you look at that, radiotherapy versus surgery, DFSOS, 5 years, 76%, 74%. Radiotherapy versus surgery, 63%, 50%. So it's not as bad as we're trying to think about it, because we are focusing on that 3% false negative rate. We're not looking at the bigger picture. The bigger picture is that patient going to die because of local relapse? So this is another paper about eliminating surgery after breast cancer surgery after chemotherapy, and this is the pooled analysis I'm talking about from the Royal Marsden. If you bring down patients, have nice biopsies, large gauge needles, small residual tumor beds, triple negative cancers, you choose, you handpick your patients, then you can bring that false negative rate down to about 3.2%. So this is what Mario showed, and it's about 169 patients. So is there a good response between breast? But I think that's the next topic is about the axilla, so I'm not going to go in there, but there is usually a good correlation between clinical pathological response and pathological complete response in the axilla and the breast. Now this is a paper that has been criticized for very obvious reasons. So this was the Early Breast Cancer Trialist Collaborative Group that published, and there was a lot of debate about this paper. It was in exams, it was everywhere. Now the problem was that this paper had pooled data from trials that did surgery and omitted surgery. And they said 5% difference in local relapse rate, let's not do this anymore. But if you drill this paper down, overall survival, surgery less commonly used, surgery commonly used. The difference there, and don't be a mathematician to know it's 3%, but the difference there is 1%. So there is again no difference in overall survival. And this is despite the fact that this trial had all these drawbacks. So it is a badly construed data mix. Patients had suboptimal systemic treatment, and I showed you in the first slide that systemic treatment makes a difference to local relapse. Surgery versus no surgery based on clinical examination, no imaging. We're talking about MRI scans, no residual disease, no residual blush, ultrasound scans. So this is now becoming refined. You're looking at PET-CT, you're looking at dynamic MRI scans. So all these things will bring that false negative rate down. Now the question is, how low can you go? At what false negative rate will you stop? If you remember the arguments we had about neoadjuvant chemotherapy and axilla, we said 10% is too high. Then we said, okay, let's do targeted axilla dissection, sentinel node biopsy, and bring it down to 3%. which is what we're talking about here. So axilla, if you look back when we were actually younger, most of you are young, I'm older than you are, but if when we were younger we were told the axilla is prognostically more important than the breast. So in the axilla, which is prognostically more important, we are happy to accept in the primary condition, if you do a sentinel node biopsy, 10% false negative. Post-neoadjuvant chemotherapy, if all the trials pool data, if you don't get 3 nodes, between 7% and 10%, and then TAD down to 2.4%. Caudal's data was 2.4%. So almost 3%. So how low are you going to go before you say, okay, this false negative result is acceptable for me? So omitting surgery after neoadjuvant chemotherapy, studies on breast omission, I mean, I'm not going to talk about this, but look at this. This is NSABP 04. These guys had 40% node positives. And there's no difference after 20 years. So that's long enough for anything to come back. And then the rest of the data you know, but I'm sure the other people will do it. So what do we know now? We know at the moment that the current clinical complete response rates are, depending on how you define clinical complete response, are more or less concordant with PCR, but we have to be very specific in our tumor biology selection, in our residual tumor bed selection, and how we get the biopsies, so intelligent biopsies. And we must try more than one prediction model to say that we got complete pathological response. We know for a fact that NAC needs refinement of breast surgery because we know that. Large tumors, small tumors, more breast conservation, suddenly it's become very fashionable. NAC has increased PCR rates, we know that. But what we don't know is this bit here, is we need to know how to analyze and identify PCR more completely, more accurately. How to implement randomization. If there is a randomized control trial, what do you tell patients? You have residual disease, but you're not going to do surgery. So you need to be empathetic, you need to be very sensible on what criteria you put into inclusion and exclusion, and then how you're going to follow the breast up. And what is your endpoints? Because that's what we discussed in the previous trial, is what are you trying to achieve with this clinical trial? So, if you look at this, ctDNA, the new fancy stuff. So ctDNA, does it help you tell you if there's residual tumor burden? Yes, it does. The presence of ctDNA towards the end of chemotherapy reflected the existence of residual disease. That's all you need to know from this busy slide. So can we use MRI scans or diffusion-weighted MRI scans, PET scans? This is a question that we need to know, because how low can you go is the question that we need to answer. So keep calm. We are having a paradigm shift. This gentleman didn't know that in 2019 with that, he'll lose his job. But it's happening. We won't lose our job. Don't worry. You still have luminal A's, luminal B's, so don't worry about it. It's not that dramatic. The question is, are you clever or are you wise? Will you vote with the clever man or with the wise man? It's up to you. Thank you.
Yes. Now, I would like to invite Dr. Atakan Sezer, and he will present us opposing views on this subject. Yes, Dr. Sezer, please.
I hope one day. Okay. Thank you. When the organizing committee just invited me this, presenting me this lecture, I feel terrible because I was talking against Ash, because I have just a scalpel in my hand, and on the other side there's a big pharma industry. And I felt myself as Kalut and David. For me, Ash is, sorry, you're not Kalut, but I feel like that, unfortunately. So and I have an objection to the title, Omitting Surgery in Neoadjuvant Setting. Okay, which patient we are talking about? Early breast cancer or local advanced breast cancer? In node negative? Triple. You're not the one that I prefer to help me. Okay. So, node negative patient with triple negative or luminal tumors, or node positive patients? Which one? Let's go. And we know that only 25% of the breast cancers are triple negative and HER2 tumors. And we well know that 65% of them will have node negative disease. And from CT Neo BC trial, we know very well that they will have very good complete clinical response, okay. But let's see what's happening in clinical node patients initially who underwent neoadjuvant treatment after staging axilla with pathological breast complete response. The positive axilla found is approximately 2.6%. They initially diagnosed as clinical node negative axilla in triple negative and HER2 tumors. If we add luminal tumors to this topic, it's approximately 7.6% of the patients who are initially diagnosed as node negative, and after neoadjuvant treatment with complete clinical response, they will have approximately 2.6% of positive axilla. Please don't forget this slide, because this is very important. And approximately annually, this is the equal number of breast cancer patients all over Romania, Morocco, Belgium, just in triple negative and HER2 tumors. And what about the patients who have clinical positive axilla or proven positive axilla before chemotherapy? After neoadjuvant setting, approximately 40 to 60% of the patients will still have positive axilla at the end. And there will be the next session will be about axilla, omitting axilla, but we will see that 90% of the patients with clinically negative axilla, okay, but 10% is still positive axilla, and again, with clinically positive axilla after neoadjuvant setting, they will have 40 to 60% of still positive axilla. So, let's go. We have only 11% of the patients who are candidates for omitting surgery. But even inside the tumor, if we misdiagnose, the local recurrence rate, not maybe all survival, but please, let's not forget the point of patients, because the fear for the patients is not only overall survival. The recurrence risk, the anxiety of local recurrence is still ongoing for the patients. So, how do we going to predict the clinical response? Clinical examination, yes, this is not acceptable, a very old study, clinical examination. And ultrasonography. This is very important for me because the negative predictive, false negative rate of axillary, ultrasonography for complete response is approximately 25%, negative predictive, false negative rate for triple negative. And HER2 tumors, it's higher. Why is it important? I will talk about it later. MRI is okay, but even three-modality imaging fails down, even. Okay, the next point is, for sure, biopsies. Those are the size of the biopsies. Please also do not forget this slide. I will talk about a little bit more about it. There are for sure core biopsies and vacuum biopsies that all discussed in the previous lectures. Okay, with 14 gauge needle. 200 patients underwent biopsies, 4 from the central, 4 from the peripheral zones. The false negative rate is 75%. This is not acceptable. Okay. And then stereotactic vacuum-assisted biopsies. In 36 residual disease at surgery, only vacuum-assisted biopsies diagnosed half of them. Only half of them. And with the stereotactic biopsy with negative results, 22% of the patients are underdiagnosed. Don't forget this also. I should talk about Hale's trial. I will go a little bit faster. With vacuum-assisted biopsies, this is 11 gauge or 9 gauge, I can't remember. 9 gauge, okay. The false negative rate is 0. This is perfect because we could talk about it. But look at the number of biopsies taken in this trial. Half of them is less than 3, and half of them is unknown number of biopsies, vacuum biopsies, and 1/3 of is lower than 3 core biopsies. But Hale proposed that at least you should take 6 core biopsies. So, negative predictive value, 100%, and false negative rate, 0. But you see, so few biopsies. And Hale also knows it very well. And in another study, with 9 gauge vacuum biopsy, the core numbers in the methodology of the trial, 6 to 12, okay. Let's see, the false negative rate is 25 with vacuum-assisted biopsies, okay. If representative vacuum-assisted biopsy, its false negative rate is 5.5%, we can say, okay. What is representative vacuum-assisted sample? 24% of the patients are unable to diagnose with ultrasonography. They couldn't see the lesion, they couldn't see the Eclipse markers. Bad visibility of the target lesion in ultrasound. Okay. What is the problem, dear friends, dear professors, dear colleagues? We try to detect the lesion with ultrasonography, okay, but the predictive rate of response of ultrasonography in triple negative is approximately 70%, 75%, in HER2 tumors 55%, and we perform vacuum-assisted biopsy in those trials with ultrasound. But we don't rely on ultrasound, but we perform our biopsies with ultrasound, vacuum-assisted with ultrasound. If it's MR guided, I know that there are ongoing trials, mammography guided, okay. But with ultrasonography, we say, okay, if it's representative, if it's not representative, what will happen? We will miss the chance, I will talk about it, of chemotherapy, post-adjuvant chemotherapy chance with these, on those patients. So, responder trial, again, Hale. Let's see, at least 12 biopsies with 7 gauge needle, at least 12 biopsies. This is 6 gauge, and I will show you the diameters of needles. 7 gauge needle, the inner diameter is 3.8 millimeters. And what is the volume of resected area in 12 core biopsies? Let's go. Approximately, it's If it's 3 millimeter and 12 core biopsies, it means 20 to 30 centimeter cube. What is our aim in surgery? Just resect the lesion of the biopsy site. Sorry, with 7-gauge needle, this is not a minimal invasive procedure. So, it's less morbid, less expense, less anxiety for the patients, or less clinical evidence. Why do we omit surgery? What is the complication rate of vacuumized biopsies? This is a review. Bleeding, pain, postoperative pain, 7%. Infection, 2%. From MICRA and NRG trial, it's 7.1% post-hematomas and breast pain. Okay, what is the complication rate of breast conserving surgery, even breast conserving surgery? 1.3. And the other point is always complain about the pain after surgery in long term, especially chronic pain. When we look, vacuumized biopsy versus surgery, the VAS visual analog scala for pain assessment, you see vacuumized in early period it's higher, but there is no randomized or controlled trial, I will talk about it, about comparing vacuum-assisted biopsy versus surgery in long-term pain. And also for the cosmetic, there is no trial. What about the cost effectiveness? Vacuum-assisted biopsy is, I don't know, is it enough for the, it's not for 12 core biopsies. 6 biopsies maybe, it's $3,000, $4,000. And maybe one of the most important thing is tumor response. Ash talked about it. We know that there are several types of tumor response. And we know that MRI investigation, examination, and pathologic response due to the hormonal status. The concentric shrinkage mode of tumor in HER2 and triple negative is approximately 60%. And what are they? The others? The others are patchy or honeycomb, scattered, or no tumor. So, if we misdiagnose, we very well know that the overall survival and local recurrence is inferior, especially in triple negative tumors, if we lose the residual tissue. So, we are trying to do this. If, especially with ultrasound. Okay, what we will do, what will happen if we don't know the residual tumor after neoadjuvant chemotherapy? You know, create X, ICE by Penelope trials. We know that if we lose it, we will lose the chance of post-neoadjuvant chemotherapy treatments. And we know that the overall survival differs in those patients if we lose them. And there is clear evidence for this post-neoadjuvant treatment benefit. Those are not my words. Those are words of Monica Morrow. In order to find one patient, we will make core biopsies to 99 patients, because only 7% of the breast cancer patients will have 0 point false negative rate in order to find, in order to omit the surgery. And Ash told about it, only 14 experts elected omitting surgery after complete pathological response proven by biopsy. from the side of patients, we are all talking on numbers, papers, but from the patients, we don't know how they will act with those anxiety, follow-up period, more radiological examination, and cosmesis with especially 7-gauge needle, 12 core biopsies, and fear of local recurrence. Sorry, I should say this. But there's no trial comparing long-term pain, vacuum biopsy versus surgery. No trial comparing cost effectiveness in middle and low income countries. No trial comparing cosmetic results with such large resected material with vacuum associated, and no trial comparing the patient anxiety. Thank you. It's very easy to throw the question to the surgeon.
Thank you, Dr. Sezer. Now it's time to take questions for the first debate. I mean to Dr. Eş and to Dr. Sezer. No questions at all? Okay, go ahead. To both. Dr.
Yeah.
Sezer.
Because it's mostly the idea of how you deal with something. So let's put things into a pragmatic perspective, so as to have an idea of how things will going to go on. If further results are encouraging with regards to omission of surgery in this selected category of patients, and so on and so on and so on, we will need trials, and I think that all these trials will be looking into these outcomes. With regards to the numbers and the citation by Monica Morrow, we were talking yesterday about evidence-based medicine versus eminence-based medicine, and these numbers do not add up, so I'm not worried about that. That's an estimate. But the truth is that we will be discussing surgery, because all the studies performed, both Jörg's studies, the pooled analysis that Marius did with the people from MD Anderson and Seoul, and I know this material because I was heavily involved in that, they suggest that this is one of the cases where patient selection is not something that we say because we don't have anything else to say. So we are talking about the patients that have favorable biology, that have got a small operable breast cancer from the get-go, unifocal, with a very clear concentric shrinkage pattern, and so on and so on and so on. So that is going to be the minority. I just think that the surgeons we need to open our mind towards the idea. But all this will be done because nobody in their right mind will start hopping over surgery if no randomized trial that will be looking at all these outcomes is performed. My question to the both of you is, shouldn't we be looking into something like a survey, patients that underwent chemotherapy and have complete radiologic response? Because I would be very, very fascinated in knowing how big of a deal is surgery for these patients.
Yeah, you see? I think I made that point in my presentation, that first of all, designing a randomized control trial is going to be tricky. And I also said, what you're going to say to the patients becomes very difficult, because we don't know how the patients are going to think or how they're going to react. And if you tell them it's a small operation, day surgery procedure, and you know 100% versus 3% false negative rate, which is what we'd have to put something on paper in the patient information sheet. So that figure has to be, it could be anything. If you think about systemic treatment, patients accept systemic treatment with a 2% benefit. If you look at chemotherapy, adjuvant online or NHS Predict, anything over 2%, and the oncologists will want to discuss chemotherapy. So there's a strong indication for, not a strong, but there's a recommendation of chemotherapy 2% and over. Now, will the patient believe that 3% and over, if there's a recommendation for surgery and have it, and if it's not such a big deal, cosmesis is not a big deal, it's, unless we do it, we won't know. I think that's the right answer, because It's going to be a difficult trial. And that's why probably people are waiting for someone else to do it.
If I'm going to.
Complete radiologic response, you can tell them, we are expecting 60% complete pathologic response. The operation is performed in a confidence manner.
Okay, let's take the answer of Dr. Cesar.
Good question. For axilla, as you thought, we accepted. No.
I'm thinking about the way, everybody's afraid of the word cancer, and they are afraid of surgery. So, regardless of that, in Greece, Turkey, England, Sweden, Germany, the knife is intimidating. And once they have been neoadjuvant chemotherapy and they have been crushed over anthracite, taxane,
Yes.
double blockades, or gorizumab, most of the women that come to surgery undergo surgery and say, this compared to chemotherapy.
Easy, yeah.
So I would really like to know if women that do you think that there is a full analysis of to have an idea of the attitude of women towards making surgery. Is it not really
Yeah, exactly. There is no deal about it.
Yeah, we say that
For the patient point of patients, we don't know.
So that's what he said. Should we do a survey to say,
Yes.
ask patients, if this was a situation you were in clinic, what would you choose?
Yes. This is a trial. This should be a trial for asking for a questionnaire for the patient. This should be. But do you know the? I mean, you're talking about your patients, but is there any questionnaire for that? I don't know.
No, that's what he suggests. I'm suggesting because if you think that this is a good idea,
Yeah, for sure, it's a good idea.
You should do it over the weekend.
Yeah, we can.
Before we talk about omitting surgery, I think we have to do what you mentioned. That unfortunately needs to stop because they have the same population. The rest, yeah. I think it's all about patient selection. So there was one trial, a Polish trial, BRCA mutant carriers, triple negative disease with a PCR of more than 90%. So this would be the right patient selection to think about omitting surgery. If you go for just triple negative disease without finding out, so who's the one who has an immune signature positive, we don't use, who's the one with intrinsic subtyping, real triple negative disease, what we don't do, then we can figure out who's the patient who will receive a PCR most likely. And then what you mentioned yesterday, we have no idea about checkpoint inhibition. If you get a PCR, and this is the main part, PCR translated in survival benefit, then you have to then you're able to find out who's the patient. What we are doing after this pandemic right now, so we use artificial intelligence to figure out who's the right patient selection, and then we can make another debate, and then maybe I don't know who will. but the patient really.
Okay.
have to continue with a new system. I mean, and all this in local anesthesia, and maybe we are very much more afterwards. It's bigger after a regular surgery.
Okay. Last word, please.
The patients, the slide that I showed in my talk with vacuum-assisted excisions, the patients that did not undergo surgery because they did not have residual disease on vacuum-assisted biopsy, underwent, everybody, regardless of age, underwent radiotherapy and boost radiotherapy. So we have to discuss what is de-escalation and what is over-treatment in this case. And this is where we need to put the patient in the game. That's what I think.
Thank you.
Now I would like to invite Dr. Hasan Karanlık from Istanbul University Department of Surgery. He will talk about omitting axillary node dissection in node positive patients after neoadjuvant treatment.
Dear chairs, dear colleagues, I will try to convince you omitting axillary lymph node dissection in N-positive patients. According to NCCN guideline, axillary lymph node dissection and nodal irradiation is the standard of care for residual nodal disease after neoadjuvant chemotherapy. You know, according to tumor subtypes, the response rate is different. We know in triple negative breast cancer and HER2 positive breast cancer, almost more than 50% of these patients you can see pathologically complete response. Let's check, let's separate patients according to their clinical, in the beginning of their clinical findings. Patients presenting with N0 before neoadjuvant chemotherapy, we know the pathological response rate is high and their survival rate is not different from each other. And this data is validated with many studies, and now this information is widely accepted. What about in node positive at presentation? Many studies we know about this. But which techniques can be used to increase the accuracy of sentinel lymph node biopsy after neoadjuvant systemic therapy in these lymph node positive patients? And the question is it accurate? And when we evaluate these studies, all these studies look for false negative rate and try to estimate residual positive lymph node after sentinel node biopsy. When you remove more lymph nodes, the false negative rate is lower, as you see here. And about in these studies, the overall false negative rate about 10%. And in these not positive patients, when we check these studies, especially in first 3 studies, you can see how often do we harvest more than 2 lymph nodes? About 50% of these studies, not more than 2 lymph nodes they removed. And in the last study, in maintained studies, it is conducted prospectively. For this reason, they removed at least 3 lymph nodes. And to improve our false negative rates, axillary ultrasound is not appropriate and we cannot use to improve our rates. And to improve these false negative rates, targeted axillary dissection or similar studies published. And if we compare with sentinel node biopsy, when we use targeted axillary dissection, the false negative rate is lower. Just targeted axillary dissection in sentinel node is the clip node in 77% of the patients, and targeted node was not the sentinel node in 4% of the patients. And when we check these sentinel node in patients with isolated tumor cells or micrometastatic tumor cells, non-sentinel lymph node metastasis is not high. The problem usually it is when patient has macrometastatic disease. The aim of the axillary surgery after neoadjuvant chemotherapy, first, provide information for response, evaluation of PCR, and the second one, provide local control. And you know these studies. After these studies published, the importance of pathologically complete response to decide to see the pathological complete response is more important, because according to pathological complete response, we will decide patient's adjuvant therapy. Also, not just other studies, in Keynote 522 studies with Pembro, when we start Pembro earlier, we can improve the survival. And as you see here, we know that 11 AMORO study or the other studies, and when we perform axillary lymph node dissection in lymph node positive patients, the non-sentinel lymph node positivity is almost more than 30%. But in post-NAC studies, when the lymph node is positive, the tumor burden is higher. Okay, according to AMORO study, when we let these patients, when we don't perform axillary lymph node dissection with radiotherapy, the disease-free survival is not different. Is it possible to extrapolate this data after neoadjuvant systemic therapy? Because over 60% of the patients, they have residual nodal disease if we perform axillary lymph node dissection, regardless of the tumor type. And this high rate, it is not a surprise. But we can deal with this problem with radiotherapy. Why? Because radiotherapy can treat gross nodal disease. We know this data from prostate cancer, rectal cancer, or lung cancer. It is a matter of radiotherapy dose and target volumes. And if we check the literature about this subject, you can see in clinically N0 breast cancer patients for randomized control study, more than 4,000 patients, clinically N0 by palpation, these patients, and 40% had PN positive in axillary lymph node dissection arm, and regional recurrence occurred within 2 years in 75% of these patients, and lower local recurrence rate with post-mastectomy radiotherapy, low regional recurrence with radiotherapy, and overall survival is not different. And in N-positive patients with radiotherapy, you can see similar results. About 5 to 25 years follow-up, more than 1,000 patients, and in these patients, lower local recurrence rate with post-mastectomy radiotherapy, no difference in regional recurrence, and no difference in distant metastasis and overall survival. Maybe this difference just worse survival in medial located tumors, maybe because of the mammalian internal lymph node positivity. And when we compared axillary lymph node dissection and radiotherapy only in N-positive patients, also you can see with radiotherapy, local regional recurrence is great. And important point that tries refuse Hallstatt's theory. Lymph nodes are not the precursor of distant tumor dissemination. Radiotherapy can treat this gross nodal disease, and with dose and radiobiological effect of is important where if we take care all these points. And with new radiotherapy techniques, better definition of radiotherapy volumes and quality assurance, we can provide local control, better disease control, less toxicity. And if you don't trust this treatment modality, my question is, what about mammary internal lymph nodes? Do you remove them? Or what about level 3? What about higher neck lymph nodes, posterior triangle? Are you planning to operate these lymph nodes as well? And if you don't perform any surgery for these regions, why you operate axilla? And the second point, residual disease after primary systemic therapy is more resistant to radiotherapy. Let's see this table. And you can see in N0 patients, 21% absolute reduction in local regional recurrence with post-mastectomy radiotherapy. And in N-positive patients, the absolute reduction of local regional recurrence is higher. What does it mean? If patient has more heavily tumor load, the radiotherapy is more useful. And the chemoresistance is not equal radioresistant. For this reason, let's see the big picture, because not just the cancer local situation, biology and host immunity is important. Clinical stage, primary systemic treatment, during neoadjuvant chemotherapy, clinical evaluation, response, imaging, all these points are important. And we should take into consideration all these parameters, not just lymph node is positive or negative. And nowadays, we don't use just TNM. We use imaging. We use PET scan. And we shouldn't decide just sentinel node is positive and I will perform sentinel lymph node dissection, because the no PCR, it doesn't chemo resistance, or not chemo resistance, the chemosensitive tumor, the response is not equal bad prognosis. And in this slide also, this is Murray protocol from Murray protocol I want to share. In PCR group, 9% of recurrences, and in this group, they treated just with axillary radiotherapy, and when we perform axillary lymph node dissection, in this group, local recurrence is higher. They, in this study, I don't want to give all details, but they separated patients, regional therapy decided according to number of PET positive axillary lymph node situation, less than 4 lymph nodes or more than 4 lymph nodes. And in this group, radiotherapy is more effective. And what about systemic therapy? We know if we use better systemic treatment, it is potential benefit of therapy is higher. And the test, not just this, and no PCR does not always mean bad prognosis, because no PCR, it is not the equal, and it's not one disease. What I can say, radiotherapy can treat gross nodal disease, and residual disease after neoadjuvant chemotherapy is not more resistant to radiotherapy, and see the big picture, and tailored therapy is the best solution. Okay, but I say over 60% of the patients residual nodal disease at axillary lymph node dissection, but when we check these patients, most patients included had advanced T stage, more than 80% had palpable nodal disease. Response to neoadjuvant chemotherapy does not follow the same pattern of spread of sentinel node, and why you just use sentinel node biopsy. You can use taxis, target axillary dissection, the dissection addition to sentinel node biopsy. And recently published study from Milano, and axillary lymph node after neoadjuvant chemotherapy, they performed sentinel lymph node biopsy, and about 700 patients, and in clinically N0 patients, axillary recurrence rate 1.5%, in N-positive patients less than 2%, and about 10 years follow-ups. And they used just single agent. Median lymph nodes was 2, and 74% of patients, they found just one sentinel nodes. And luminal A patients in N0 patients and breast PCR affect survival. And in National Cancer Database, they found higher axillary recurrence. However, in subtype analysis, in luminal type, and when patient has just only one lymph node metastasis, these patients have had similar survival. And from our country in neocentric study, and more than 300 patients, and after neoadjuvant chemotherapy, median number of sentinel nodes was 3. 40 patients had macromet, 33 micromet, 19 isolated tumor cells, and isolated axillary recurrence was 0 in about 3 years follow-up. As a summary, if you still believe in the Hallstedian approach, if you evaluate your patients only by palpation, if you don't assess the risk before after systemic therapy, and if you are an all or nothing kind of person, and if your radiotherapy team is still using old fashion modalities, and if you cannot see the big picture, yes, you can perform axillary lymph node dissection. Residual disease is not one disease. Stand against Hallstedian concept and axillary lymph node dissection for all residual disease, and tailor therapy according to risk and benefit. Of course, studies are ongoing, and thank you for your attention.
Okay. Thank you, Dr. Karanlık. It's now the turn of Dr. Mark Till, isn't it? He will talk against the arguments of Dr. Karanlık now.
Yes, thank you for the ability to talk against it. I thought the easier job because I can follow along the guideline. But thank you for excellent talk and excellent ideas regarding systemic treatment. But first of all, I have to say we have to improve our systemic treatment to land there, that we don't go for, let's say, an extensive surgery. But this is something we have to figure out using gene profiling and using classifiers and so on. And yeah, so I'm just waiting for my slides, and I hope that I can convince you all that axillary dissection is without losing contact to the big picture, something that we have to do because we don't have data at the moment that really prove that concept of omitting axillary node dissection. So meanwhile, thank you for being invited to this Congress, and thank you for the very nice evening yesterday we had. So it made my night shorter because I had to prepare the talk after dinner. Yes, you did the same. Oh no, you manipulate. Yeah, so we I can. Do you think it will work? Okay, perfect. So yesterday we had a chat about ChatGPT in the bus. So this is the opener of my talk, because I thought we will have a debate, but let's use artificial intelligence to add something. And here we are. So I think omitting axillary node dissection in YPN plus is not possible. Again, my conflicts. Again, nothing. And there's a ChatGPT. Maybe it's the problem of ChatGPT. So I thought I just ask an artificial intelligence, is an axillary dissection still the gold standard after neoadjuvant chemotherapy with YPN plus? And it's a very polite answer ChatGPT gave, because it says in some cases, axillary node dissection may still be recommended if sentinel node biopsy is unable to detect sentinel lymph nodes, or if there are specific indications such as persistent nodal disease, so this is the point, or residual tumor. And regarding the gold standard, axillary node dissection is reserved for, again, specific cases, whether persistent positive lymph nodes, this is the issue, or contraindications. So does this help us? I don't know. Regarding neoadjuvant chemotherapy, I think we made a really good progress in response-guided treatment. So we had this very interesting and fruitful discussion yesterday when we discussed the case. What is response-guided treatment? It's an in vivo sensitivity testing, and it took ages to convince the patient that this is the right approach. And this is what I thought when we had this debate before. So if I talk to a patient and said, well, we can omit surgery, are you satisfied? Are you crazy? I want to get rid of the tumor. But there is no tumor, I think, because I have this algorithm. And so this is maybe another issue. So in triple negative disease and HER2 positive disease, we have to select patients who are at risk, of course, for post-neoadjuvant treatment options. And that means we have to clarify, is the patient at risk? And therefore, we need the lymph node status. For locally advanced, including lymph node status that is positive, we are able to allow de-escalation of surgical extent in breast and axilla. So this was shown yesterday. And in the patients who converted from node positive after neoadjuvant chemotherapy, in the YCN0 patients, axillary node dissections has been replaced by less invasive staging procedures, such as TAD or TLNB or SLNB. But this is the fact, but this doesn't include the information that comes out of these procedures regarding maybe still a positive lymph node status. So how many patients have a YPN plus disease? And of course, this is data from Thorsten Kühn, this is data from the Sentina trial. In this study, 900 patients, so 40% of the patients were clinical node positive, and they converted to a clinical node negative disease, or they remained clinical node positive. So more than 80% converted to a clinical node negative axilla, and 16% remained positive via a clinically. So how many patients in the end, and this is 30% of the patients from the initially node positive patients, 30% still stayed with a positive lymph node status after the neoadjuvant chemotherapy and after a proper axillary intervention. So does the NCCN guidelines help us? Well, this is what I highlighted in red. This is just before neoadjuvant chemotherapy, and this is after neoadjuvant chemotherapy. And you see if preoperative chemotherapy was given, axillary dissection for residual disease or sentinel node biopsy when nodes clinical negative is indicated. But that means sentinel node biopsy if it's clinically negative, but it doesn't help us how to proceed, and axillary dissection for residual disease by exam or imaging, and this doesn't give us the idea what happens after the surgery. So this is our AGO guideline again. So we do have algorithms, and if you're interested in, I recommend just to go on the homepage. It's www.ago-online.de. So this is available there for free. Around 450 slides incorporating all our treatment recommendations from Germany. And we do have some algorithms there, and I think this is quite interesting. So this is how to perform in the axilla after neoadjuvant chemotherapy. So if we have a initially node negative disease, and then we perform neoadjuvant chemotherapy, then we perform, of course, the sentinel node biopsy, but then we have the result resulting in isolated tumor cells or in micrometastasis. What do we recommend? Isolated tumor cells. We recommend in a plus-minus situation, so you can do, you don't have to do, an axillary dissection. But for micromets, we recommend an axillary dissection, and of course, for macrometastasis, we recommend an axillary dissection as well. So why do we recommend in low volume residual disease to perform an axillary node dissection? Because we want to know what else happens besides micromets and besides isolated tumor cells. So we know that we have affected non-sentinels in more than 60% of the cases, and if you have positive isolated tumor cells in 17%. And this really matters due to the fact that we have to take into account what kind of treatment, and then we are in a post-neoadjuvant setting, what kind of treatment has to follow if we know that we have maybe more lymph nodes affected than before, and the treatment didn't really, and the tumor didn't really respond to the chemotherapy. So what are the Germans do? So this is data from a questionnaire from the Northeast Society of Gynecological Oncology, and you see that 30% of the colleagues perform axillary node dissection in micromets. A quarter performs radiation, and nearly the half says no further axillary intervention. So, I mean, you see how important it is that we have the debate right here. So we go back to the algorithm. So the first part is done. So let's go to the second part. Initially, note patients. So what do we do? If we still have a positive lymph node by image or by core biopsy, so you could perform another core biopsy. And Thorsten said yesterday from the Axana study, if you have the idea that you still have positive lymph nodes by image, maybe you perform a core biopsy, and this is implemented in our guideline because from the interim analysis of the Axana study, it says that 30% of the patients, they don't have a positive axilla, they don't have positive lymph nodes, but it seems that they have positive lymph nodes due to the fact that you see that in ultrasound or in other diagnostics. So this is clear that we have, if we have positive lymph nodes, then we only have data for axillary dissection. But what with the patients where you have converters? So we are able to perform TAD, that was nicely shown from the prior talk. But then if this results in isolated tumor cells, again, a plus-minus recommendation for an ALD, or macro or micrometastasis with a plus for ALD. So this is the data we have at the moment. But what is the favorite procedure? Maybe not just in Germany, in the Northeast Society of Gynecological Oncology, maybe from the U-Breast. And there are 7.6% of the colleagues, they say, we want to omit an additional axillary node dissection, and we want to replace that procedure with radiation. So I think this is the alternative we are talking about. So do I go back in the UR, or do I send my patient to the radio-oncologist? So is radiation of the axilla an alternative? And yes, we have the Amorous trial, but this is a trial with an adjuvant setting, and there were no patients included undergoing or who underwent a neoadjuvant treatment. Of course, we have the issue of lymphedema, but are we really doing the same surgery in these days that was done in the Amorous study? So are we really removing 10 lymph nodes? Are we really removing maybe then 15 lymph nodes? So what are we doing? Are we removing maybe 5 lymph nodes? Are we wondering after neoadjuvant treatment, I removed 4 lymph nodes, but I had no additional lymph nodes? When you think of the Texas trial, palpation by ultrasound, by whatsoever. Yes, we have a lymph node issue, but this has always to do something with the surgeon and how precise the surgery was. There was an update published in San Antonio 2018 with a slightly higher recurrence rate, a local recurrence rate for the patients who underwent radiation, but of course not statistically significant. No updated quality of life data had been presented. But this is brand new. That was published in JCO this year. So the 10-year results of the AMARAS trial. And you see that, again, a slightly but not significant difference between radiation and operation was detected regarding the 10-year local recurrence rate. These are the curves, the Kaplan-Meier curves out of the current publication. And there you see, well, this is what we know. But again, these are not patients who underwent neoadjuvant treatment before. So coming back to the low volume residual disease, what kind of data we have, and you nicely presented data from Tracy and Nu, and all these patients, so 700 patients, they underwent neoadjuvant chemotherapy, and prior surgery, they had a conversion or from the beginning a clinical node negative axilla. But nevertheless, and this is data I presented you just with my sentence when I showed you the algorithm, 70% had additional positive lymph nodes when they had isolated tumor cells, and 64 additional positive lymph nodes with micromets. And with macromets, 60% had additionally positive lymph nodes, and of these, a third had more than 3 positive lymph nodes. So is this interesting? Yeah, maybe for post-neoadjuvant treatment. So this is happens when you write a talk in the night. Again, this is data from Wong when we had translated this. So okay, we find additional lymph nodes, but what does that mean to the patient when we talk about treatment, when we talk about prognosis? And in the Wong paper that was published 2019, you see that the 5-year disease-free survival and the 5-year overall survival showed the impact of residual tumor cells and micromets following neoadjuvant chemotherapy, and there was a significant difference regarding the survival outcome in these patients. So let's make an interim conclusion. So low volume sentinel node disease after neoadjuvant chemotherapy is not an indicator of low risk. I think this is clear. Higher tumor load, that was mentioned before, in YPN plus compared to PN1. So this is clear as well. So we have a higher tumor load in these pretreated patients. We have chemo-resistant residual disease, but we have no idea what kind of resistant markers we have to measure. And all of us know that once you treat a cell, the cell clone will differ, will alter, and then you get resistances. And we know this quite nice from metastatic disease, that you get acquired mutations. You get a lot of acquired mutations, and we are really happy to have an ERSA1 mutation we can measure, but unfortunately in metastatic disease. So there are chemo-resistant, there is a chemo-resistant residual disease. We have long-term data of the AMARAS, but that are not really translatable in the post-neoadjuvant setting. I'm sorry for that. And quality of life data we have, and this is something we are aware of, and this was the reason why we de-escalated our surgery, that we have superiority regarding lymph node edema for radiotherapy. But this is really unclear when you talk about neoadjuvant pretreated patients. So I think we have to wait for this study. And that was mentioned yesterday, a proper prospective randomized trial, the Alliance A11-202 schema, to randomize patients after neoadjuvant chemotherapy having a sentinel that's positive, and then randomized to axillary node dissection and radiation. And we have to take into account what I mentioned before. So you are aware of the Monarch E study. So this is just a study that incorporates, of course, the number of lymph nodes. And there are a lot of studies following that incorporate the CPS-EG score, not the RCB score, but the CPS-EG score. And this will tell us, do we need some more post-neoadjuvant treatment, or do we need post-neoadjuvant treatment, especially in the endocrine responsive disease? And as you can see, no, you don't can see, but 1,000 patients underwent, in this trial, underwent neoadjuvant chemotherapy. And of course, it mattered what kind of lymph nodes you had before surgery. But if you had more lymph nodes after neoadjuvant chemotherapy because you performed an axillary dissection, then patients were available to receive abemaciclib instead, in combination with an endocrine treatment, instead of just having an endocrine treatment. And the results we have is an improvement of the invasive disease-free survival, but more important, a significant improvement of the distant relapse-free survival. And take a closer look to the numbers here. I mean, these are the numbers of metastasized patients. And with this trial, the number of metastasized patients could lower nearly by 50%, and this means we have long-term survivors coming out of this trial. So I have to conclude with all that. Axillary dissection remains standard of care for the CN plus, Y, CN0, and then, of course, YPN plus disease. Regardless what you do, sentinel biopsy or TAD, it's about the result after these de-escalating axillary intervention strategies. Unless evidence from prospective trials is available to demonstrate non-inferiority of radiation and improved long-term quality of life. Thank you.
Thank you very much, Dr. Thiel. Any question or contribution from the audience?
While I understand the need for de-escalation, we should not forget the fact that in the studies that discuss not only survival but also locoregional recurrence, both the pooled analysis from the German breast cancer group, the patient-level meta-analysis that Adonis Valakis did from Sweden with material from Spain, Austria, the States, and so on, and the recent data presented from the I-SPY, where the endpoint was actually whether relapse had any role depending on breast conserving and mastectomy. Axillary status post-neoadjuvant is a stronger prognosticator for local recurrence and survival. So it is information that we still need to know. That was just the point.
No, I totally agree on that. So we had this discussion yesterday. So what has a higher value? The PAT-CR in the lymph nodes or in the breast? Of course, in the lymph nodes. Of course, we know if you have a PAT-CR in the lymph nodes, then you have if you have a PAT-CR in the breast, then you may have a PAT-CR in the lymph nodes. But this is a stronger predictor. And I think what will happen right now is that we have to take into account these lymph node status, as you said, after neoadjuvant treatment, because we know this is a strong prognostic parameter, yes. I agree on the health check theory that if you have lymph node metastasis, it's not, let's say, a sign for a more severe metastasization, because this belongs to the subtype, and this has to be treated by systemic treatment. But nevertheless, we will find out how to rank the positive lymph node status after neoadjuvant therapy regarding the post-neoadjuvant treatment. And this is something we have to figure out. And we have this intensive discussion in Germany regarding the NeoRAD trial. So this is the trial I mentioned yesterday, where we perform radiation before the surgery. And everyone really was afraid of, oh wow, then we will miss informations out of the axilla later on, because we perform radiation first of all, and then we perform the surgery, and then we miss the information regarding the residual disease in the axilla. And this is something we are not able to take into account. So is it the same value performing radiation to the axilla instead of performing systemic therapy? Because you may miss patients who will not have a negative lymph node status after neoadjuvant chemotherapy when you perform radiation in front.
Thank you.
Any more questions?
Okay, thank you for the comment. Thank you. Very important.
Doktor Görkem.
Yeah, you're highly welcome all the time. No, thank you for the very important comment, and I think this is a really important evidence for all the patients, and this is how I talk to the patients when they say, can you remove the breasts, please? I said, why? Because I want to avoid radiation. And then I always think, there are several trials, but there was an analysis done by Kaiser Permanente, so this insurance from California, and they showed really nicely that in the last 10 years, of course, the number of mastectomies increased. But there was an inverse correlation with mortality. So you have an overall survival benefit if you have a breast-conserving surgery, that was mentioned yesterday in the talks, I think because of radiation. Yes, that matters.
So can I just make a point? So you know I like to come to conferences and just make people think. So I want you all to answer the questions which are on the screen, okay? So let's say primary tumor bed. Let's say we've got a complete response. So we put 0 there. Overall cancer cellularity, we've got a complete response of 0. Percentage of children in situ disease, 0. Okay, what number do you want to put there? Let's put 1. 1 lymph node, okay?
Yeah.
1 lymph node positive. With the macromet, let's say 5 millimeter macromet, okay? Now I'm going to ask you to calculate the residual tumor burden, because you know RCB directly is proportional to the prognosis. So there you go. Oh. Yeah, sorry. Now let's go down there, and then we put calculate. You got a 1.315 residual tumor burden, so RCB 1. Okay? Now let's just make this more fun. You did a sentinel node biopsy, and you took out 4 lymph nodes, 1 is positive. Then you did an ALND, and you took out more lymph nodes, and 5 are positive. The largest met still is 5 millimeters. Now let's see what happens here. Since we are using ChatGPT, let's use some more tools. Just make it fun.
No difference.
Yeah, your RCB does become 2, but marginal difference. So you have to ask yourself, and this is just being deliberately provocative, because it's good fun. Otherwise it becomes very, very simple. By knowing more in a patient that has chemo-resistant disease, are we gaining anything? So let's ask the 2 debaters. Because this patient is at, and this is again, I'm being deliberately provocative, although I would do a clearance, because that's what the guidelines tell me to do. But in a patient that has chemo-resistant disease, and we don't know what to do, because like you said, we don't know the molecular profiling of that tumor, we don't know how it is mutated, we don't know what kind of treatment is going to work. We think cytopine TDM1 is going to work, but it doesn't work in all the patients. So you're still going to get a subset of patients that it doesn't work in. So in these patients which are at a higher systemic risk, if that disease is micrometastatic, giving them maximum local control, is that doing them any favors by maximizing also their risk of lymphedema?
Yeah, this is a brilliant question, Ash. Really brilliant question, because this reminds me to the presentation of Lajos Pusztai. I think it was at ASCO for the Keynote 522 study, when he adjusted the RCB score 1, 2, 3, 4 to the efficacy of pembrolizumab. And what we have seen there is that if you have a RCB 1 or 2, well, we could omit pembrolizumab. So in RCB 3 and 4, yes, we need pembrolizumab because there is a significant difference. And that shows us that there are tools, but we have to implement these tools and go along with these tools in clinical trials. And as long as we don't do that, we have these brilliant conferences and we have like a think tank and everyone is thinking and goes back home and think, oh, this was a really good conference because you have some fruitful thoughts and you can work on it and you meet others and we will chat to each other how to develop maybe solutions. But this is the case, yeah. So how high is the effect of a marginal effect that you have seen, that you have shown in our patients? So again, it's about patient selection, yeah.
Neslihan.
When she will get axillary lymph node dissection, the answer is no. I mean, the radiation oncologist will radiate all the three levels, even though the patient underwent an axillary lymph node dissection. Most probably, this is Görkem. Where is Görkem? This is my suggestion. If she is treated at Istanbul University, the radiation pills will not be changed, and the patient still will have the same systemic therapy as, for example, TDM1 if she is HER2 positive. And so the tumor biology will just will be there to change the prognosis of this patient. So and she will get twice more lymphedema since she had underwent a lymph node dissection. So the life quality will be worse.
Yeah, you're right. So my point is always, I want to know.
The tumor biology is the key point. That's my point.
Yeah, all right. No, thank you. So I want to know the lymph node status regarding the decision I do later on for my systemic therapy. And I know that radiation works all the time. And I don't have to wait 10 years, 20 years, so radiation works. The question I have is, has the radiation the same value in the post-neoadjuvant setting that it has in the adjuvant setting? So this is what I don't know, because what we are doing, we are clustering patients out of a big subset of patients who are at higher risk because they didn't respond to chemotherapy. And this is the reason why we had this proof of concept from the Catherine study that a post-neoadjuvant treatment works. But the question is, do every one of these patients need such a treatment? And the more important question is, who are these patients? So I want to figure out who are these patients. Do I have any resistant markers? So this was your story. Do I have additional informations? And this is something we have to work. All of us. So I'm in Chicago next week. And then again, we're talking about gene profiling, we're talking about classifiers, we're talking about tumor-infiltrating lymphocytes. Do we do that in daily routine? No, we don't do that. We're talking about, we're having good ideas, but we have to implement that in our daily strategies. And therefore, we have to go along with these approaches in clinical trials. And this is what we try in Germany with the German breast groups. I'm one of the members of the scientific sub-boards of the GBG, and this is something we want to implement. And predictive techniques as well. So we talked about symbiosis yesterday to incorporate all informations we have from MRI, metabolic informations, predictive informations, how does this tumor respond to chemotherapy, and then maybe we can make better decisions later on to omit what we're not omitting at the moment.
Once more, thank you for all attendance, and special thanks to our colleagues from abroad who join us and give valuable experiences and share with us. Thank you very much. Lunchtime.
he managed this course.
Hello, everybody. First speak is from Dr. Professor Sibel Özkan Gürdal. Title of her topic is Instrumentation and Ultrasound Breast Examination. Stage is yours, Dr. Gürdal.
Thank you, dear chairs and dear colleagues. The first speech of the course is Instrumentation and Ultrasound Breast Examination. When you any scar, skin retraction, and asymmetry and skin lesions should be evaluated with inspection before the ultrasonographic examination. Ultrasonography deep setting is adjusted so that the pectoralis major muscle is visible. Gain is adjusted so that the adipose tissue is medium gray. The key point for positioning is the immobilization of the breast tissue. The patient should be positioned to minimize the thickness of the breast area being evaluated. Examination is performed with the patient in the supine oblique position and the arms under the head. Weights can be used to support the position. Generally, the following positions are used. Medial and inferior lesions, the patient is supine with the ipsilateral arm over the patient's head. For inferior lesions, the breast can be held superiorly. For the lateral lesions, the patient is opposite posterior oblique with the ipsilateral arm over the patient's head. The degree of the obliquity depends on the breast size, pendulousness, and the location of the lesion within the breast. With large breasts, a complete decupate position might be the best. For the superior lesions, the patient is supine, opposite superior oblique or sitting, with the ipsilateral arm over the patient's head. If the lesion is superficially located and is palpable in the erect position, the patient should be examined, at least for a part of the procedure in this position. Remember that the breast appears thicker in the erect position, so this is not appropriate for the posterior lesions. During scanning, the transducer should always be perpendicular to the skin surface. It may be helpful to use thick layer of the gel to evaluate the lesions on or just below the skin. The degree of the compression should be adjusted according to the breast structure and the characteristic of the lesions that we examined. When you scan the breast, the examination plan can be transverse, sagittal, radial, or anteradial. We should document findings in two planes, transverse longitudinal or radial anteradial. Grid scanning pattern, scan up and down the breast in rows, making sure you overlap each row slightly to ensure no breast tissue is overlooked, and rotate into the sagittal plane and repeat the pattern. The other scanning pattern is radial scanning pattern. The breast is scanned and described as a clockwise. Begin at the 12 o'clock in a sagittal plane with the toe of the probe at the nipple. Scan by rotating the probe around the nipple. Depending on the breast size, a second pass further from the nipple may be required. If pathology is identified, rotate the probe 90 degrees in the anteradial plane. The entire breast can be scanned in the sagittal and transverse plane, and radial and antiradial shapes can be applied. The also retroidal area is also examined. Also, there are some probe using techniques. First is alignment. When tracing a structure along the trace, the transducer is moved into the craniocaudal direction. Another technique is rotation. Internal and external rotation movement of the transducer provides longitudinal viewing. The other is tilt. The best images are obtained when ultrasound sees the tissue at 90-degree angle. Retroareolar area is a difficult area. Since there is an air in the retroareolar space, a 90-degree view is not sufficient to find the lesion. The retroareolar region is evaluated both with the probes at the 90 degrees to skin and also using tilt movement of the probe. Scanning the nipple and the subareolar region is challenging because the nipple pushes the breast substance appearing as evoke the shadowing nodule in the subcutaneous area. The tightly packed ducts in the breast are parallel to the ultrasound beam, making these difficult to see in case of pathology. With nipple lesions, it is helpful to roll the nipple using the probe to scan it along its side. This improves the angle of the ducts to the ultrasound beam, making for easier and better visualization. And in some cases, the breast can be supported by the other hand to optimize the nipple probe geometry. This gives the highest quality images of the area, but has a learning curve because the nipple tends to slip away. If you find a lesion, you should examine it by using radial technique. Findings should be documented in both radial and antiradial planes. Lesions characterization with ultrasonography is highly dependent on technical factors. Breast ultrasonography examination should be performed with a high resolution screen and high frequency probe. Gain settings, focus region selections, and field of view must be optimized to obtain high quality images. The field of view specifies the depth setting of the tissue to be displayed on the monitor. When investigating lesions, the evaluated area should be deep enough to include the breast tissue and posterior pectoral muscle. The field of view should not include the pleura or lung. Once a lesion is found, it may be tempting to reduce the depth or zoom in on it. But both can lead to ambiguous misinterpretation of contours of the mass. A large settings of form also results in smaller lesions being visualized and insufficient characterization. Panoramic imaging available in some probes or dual sequence systems that combine image halves can be used to show all large lesions in one image. There should be a timetable for the lesion location. The lesion should be recorded according to the clock phase, location, and distance from the nipple. Document any pathology found in two planes, including measurements and any vascularity. Also note the size, depth, and distance from the nipple. In reporting, the size of the lesion should be determined by measuring the maximum dimensions in at least two planes perpendicular to each other. It is also recommended to measure in a vertical plane. It is also recommended to document power color Doppler image to document the vascularity of the lesion. Ultrasonography findings should be correlated with clinical, physical, and other imaging findings. BIRADS terminology should be used for standardization in lesions, identification, and classification. Use BIRADS sonography categories for reporting include shape, orientation, margin, echo pattern, posterior acoustic features, spatial characteristics, vascularity, and surrounding tissue. As a result, the findings should be interpreted and possible diagnosis and recommendations should be presented. And lastly, for a quality documentation, Ultrasound images and reports should be stored in a digital media if possible. Comparison with old examinations is possible in properly maintained systems. If breast ultrasonography is performed to evaluate clinical signs and or symptoms or findings in mammography, MRI or other imaging modalities, it must be indicated in the report. Ultrasonography results are kept in the same file with the mammography films in the archive. And thank you.
Thank you, Dr. Gürdal, for your excellent presentation. Any question or comment from audience? We can take one or two questions or comment. Okay.
Thank you. The second speaker is Beyza Özçınar. She will speak about the anatomy and basic of breast ultrasound.
Dear chairs and dear my colleagues, today my subject is anatomy and basic of the breast ultrasound. Today, dear chairs and dear my colleagues, today my topic is the anatomy and basic of breast ultrasound. We know that the human ear hears about 20 to 20,000 hertz, but while the ultrasound works with a sound of over 20,000 hertz. In breast, normally we use the gray scale. The other name of the gray scale is the B mode, brightness mode. Commonly referred as the B mode. And the use of the gray scale imaging in ultrasound renders a two-dimensional image in which the organs and the tissues of interest are depicted as points of variable brightness. And grayscale is used for assessing the color shading in between the products. And working principle of the ultrasound is the narrow length of wave, constant speed of motion, and reflection from the tissue surface. And the sound waves leaving from the transducer give different echoes according to the surface they hit and display different gray tones on the screen. The other important point in ultrasound physics is acoustic impedance. Acoustic impedance is the product of the density and speed of sound in the tissue. As the difference in impedance between two tissues increases, more sound energy is reflected and less is transmitted. Reflection of a sound wave occurs when the wave passes between the two tissues of different acoustic impedance and the fraction of the wave bounces back. This forms one of the major principles of ultrasound imaging, as the ultrasound probe detects these reflected waves to form the desired image. And the resolution or the clarity of the ultrasound image is based on the ability of the equipment to detect two separate reflectors, two separate echoes in tissue, and display them as separate reflectors on the monitor. When the frequency of the transducer increases, the wavelength decreases, and the resolution of the two objects is good. When the frequency of the transducer decreases, the wavelength is increased, and the poor resolution of the two objects. The first picture is with the low frequency transducer, and the second picture is with the high frequency transducer, and in the second picture the resolution of the lesion is better, you see. And the relation between the frequency and the penetration is also inversely proportional. High frequency has shorter penetration and low frequency has the longer penetration. We use high-frequency transducer in breast ultrasound, high frequency with shorter wavelength and shorter penetration, but good resolution. The other important point is using a jelly between the surface of the surface and the transducer. If there is an air between two surfaces, then sound wave cannot pass through the tissue and no image is formed. For breast ultrasound, we need a ultrasound console and also the monitor and a linear transducer with about 7.5 to 14 megahertz frequency. Now this is the breast anatomy. You know the breast is a modified apocrine sweat gland, and breast is situated at the anterior chest wall between the second and the sixth ribs from the sternum to mid-axillary line at the lateral edge, and lipid is located at the fourth intercostal area. And breast have lobes, about 15 to 20 lobes, and each lobe has 20 to 40 lobules, and each lobule contains 10 to 100 acini. And the breast is surrounded by the superficial fascia and resting on the deep fascia overlying the pectoralis major muscle. Also, we look the axillary region during the breast ultrasound, and the borders of the axillary regions are: the lateral border is formed by the latissimus dorsi muscle, the superiorly by axillary vein, medially by thoracic wall, and inferiorly by the junction of the serratus anterior and latissimus dorsi muscles, and the posteriorly by subscapular muscle. The 75% of the lymphatic drainage of the breast into the axillary lymph nodes, and the remains to the internal mammarian and suprascapular lymph nodes. There are 3 levels of the axillary lymph nodes classified by the position to the pectoralis minor muscle, and the level 1 is located lateral to the pectoralis minor muscle. The level 2 is the posterior to the muscle, and the level 3 is medial to the muscle. These are the internal mammarian lymph nodes located between the ribs, lateral to the sternum, with the internal mammarian artery and vein. In normal breast anatomy, in ultrasound, we see the skin as a white, fat lobules in gray, Cooper ligaments in white, fibroglandular tissue in white, and ductus normally is not seen. If it's dilated, seen as black, and chest wall is white, and ribs black, and the fascia is white. The normal sonographic anatomy, there are 3 layers, and these are the skin, subcutaneous fat tissue, and breast gland. You see here, as a white is skin, the black one is the subcutaneous fat tissue, and this is the breast tissue. This line is the dorsal fascia. This area is the pectoralis major muscle, and this is the pleura. You see the different breast tissues here. This is the premammarian fat layer, and this layer is the mammarian layer, and this area is the retromammarian area. This is the pectoralis major muscle. Again, the normal breast image. This is the fat tissue, the breast tissue, and the retromammarian muscle. Here, see as in colors. This is the skin. This layer is the fat layer. This is the mammary gland and muscle. You see the rib as a black and the lung. Here again, the 2-color image. You see the rib. This is the lung, seen as black. This area is the muscle, and this is the breast tissue. And again, the breast tissue here. This is more fatty tissue. Again, you see in white, these are the Cooper ligaments. These are the fat area. The breast tissue is fatty also. And this is the fibrocystic breast tissue. This is the fibrotic and cystic areas. This is the fat layer. And also this area is the pectorals major muscle. You see the ribs and the pleura. This is the breast tissue in menopausal women, and fatty replaced the breast tissue, and this is the muscle. Also, we see the different images in the same breast with different areas. This is all the same breast, but different parts of the breast, and you see the different images. This picture is from the retromammarian area. You see the dilated ductus. You see the retromammarial area as a black, and you should be careful at that area. This area, and this is the ductus you see in black. Again, here the retromammillary area. You see this as like a lesion, but this is the nipple areolar complex, it's air. And also we look the axillary lymph nodes during the breast ultrasound. Normal, this is the normal axillary lymph node. You see the thin cortex and a fatty hilus and a smooth surface, ovoid in shape with smooth borders. These are the sonographic images demonstrating the lymph nodes classified as morphologically normal. These are, the others are suspicious. You see the ovoid position, the thin cortex, and the fatty hilum. You see again, these are normal appearance, but you see here the cortical thickness increases. If the cortical thickness increases more than 3 millimeter, it is the pathologic. You see the increased cortical thickness here, again here. These are the hilos of the lymph nodes. These lymph nodes are suspicious for pathology. These are the benign appearance. Again, this is the normal lymph node. You see the thin cortex with fatty hilus, ovoid appearance with regular borders. And these are also the sonographic images demonstrating some lymph nodes. You see the cortical thickening here. The black areas is the cortex, thickened cortex. You see the all thickened cortex. With the hilus, marginalization of the fatty hilus. Here you see the hilus. And these are all the pathologic lymph nodes, but these two, you don't see the fatty hilus. In picture E and F, there is more advanced cases and the total absence of the hilus. You can see these are all pathologic lymph nodes. That's all. Thank you for your attention.
Thank you for your good presentation. Is there any comment or question from the audience? Thank you.
Third speaker is Dr. Sertaç Atagüler, and his topic is, title of his topic is Documentation and Reporting.
Thank you. Thank you for the organizing committee for inviting me to this mini Senus course, firstly. Now I'll talk you about the documentation and reporting in breast ultrasound. First, I want to say that we are not radiologists, we are just general surgeons, and reporting and documenting the breast ultrasound is not our work, but we have to understand those kind of reports and documentations when the radiologists send us for our patients and for their reports. So, how to define the findings in breast ultrasound and which features to note in the report have been described in the ultrasound lexicon and the breast imaging reporting and data systems BIRADS. Breast ultrasound report structure is in 8 basic steps. First, we have to indicate the why we are making this breast ultrasound, the indication for the examination. For statement of scope and techniques of the breast ultrasound examination, for the succinct description of the overall breast composition, clear description of any important findings, for the comparison to previous examination or examinations, including the correlation with physical examination, mammography, and if we have any magnetic resonance imaging findings, for composing reports, assessment, and the last step is the management. And the statement of scope and technique for breast ultrasound examination in 2 basic steps. First, the scope of examination and the technique. Whether the examination was directed or targeted to a specific location, or whether it was performed for supplementary screening. And also for indicating who performed the examination, the radiologists, or a surgeon, or someone else. And the reporting observations relevant to the interpretation and the position of the patient during the examination is so important. We have to express this position in our reports. If the breasts were imaged in both supine or lateral decubitus position, the patient was imaged in seated position, the position in which she feels left breast thickening best, and something like that. In standard reporting system, there are 7 basic steps. I will shortly describe those basic steps step by step. First, the indication. Firstly, in breast ultrasound report or documentation, we have to describe the indications for the study. This is the first step. Is it a screening or diagnostic or a follow-up breast ultrasound imaging technique or an examination? To mention the patient's history, or if a breast ultrasound is performed, mention if the breast ultrasound is targeted to a specific location or a supplementary screening. The reason for the examination is so important then. What are the most common indications for breast ultrasound? First, confirmation and characterization of mammographic or magnetic resonance imaging abnormalities as the initial imaging technique for young, pregnant, or lactating patients. Identification and characterization of palpable abnormalities noted on clinical breast examination. Identification and characterization of localized breast symptoms such as breast pain, fullness, nipple discharges. Identification and characterization of non-palpable abnormalities detected on other breast imaging modalities, guidance for percutaneous and surgical procedures, evaluation and assessment of the breast after surgical or medical therapy, preoperative evaluations of breast and axilla in diagnosed breast cancer, identification and characterization of abnormalities associated with implants, if there are implants, evaluation and assessment for radiation therapy planning, and intraoperative assessment of lumpectomy margins. These are the most common indications for us to make a breast ultrasound examination. In standard reporting system, the second basic step is the breast composition. We have to describe the breast composition. There are 4 basic A, B, C, and D steps. The A is the breasts are almost entirely fatty. The B is there are scattered areas of fibroglandular density. C, the breasts are heterogeneously dense. D, the breasts are extremely dense. And the 3 breast ultrasound descriptors for tissue composition: homogeneous background, echo texture with fat, homogeneous background echo texture with fibroglandular scenic, and the heterogeneous backgrounds echo texture. These are the simple images. And the third step for an breast ultrasound reporting is to define describe the important findings like mass, asymmetry, architectural distortion, calcifications, and associated other features. The date and time of the examination must be written in our breast ultrasound documentation or reporting. A unique patient identified must be described. The lesion location described by either written or pictorial methods. And also at least 2 sets of lesion images must be published, measuring in 3 dimensions, including the length, width, and the height of the lesion to the breast ultrasound report, correlating with the physical examination of the breast and appropriate imaging studies. The morphological descriptors of shape, margin, and orientations must be described. Lesions' effect on the surrounding tissue, if there is, must be described. Recognition of special case findings, and for bilateral findings, describe all the findings for each breast every time. And the fourth step is the comparison to previous studies. Awaiting previous examinations for comparison should only take place if they are required to make a final assessment. We have to correlate our breast ultrasound examination with the physical findings, mammography reports, magnetic resonance imaging reports, and other imaging studies. Our standard reporting system, the 5th step is the final assessments category. Here we are using the BIRATS category from 0 to 6 and the phrase associated with them. And the BIRATS Atlas is 2013. According to this atlas, there is assessment procedures. For example, for messes, its shape, orientation, margin, echo pattern, posterior features, if there's calcifications or not, associated other features, and special cases. And according to the BIRATS, if it is a category 0, it is an incomplete and need additional imaging evaluations. No likelihood for any cancer. Category 1 is a negative report for the BIRATS. It is in its management. It's a routine screening, and essentially 0% of this kind of lesions are likelihood for malignancy. In category 2, it is a benign lesion. Again, management is routine screening, and essentially 0% of this kind of lesions are likelihood of malignancy. And if it is reported as the category 3, it is probably benign, and it's for its management short interval. We recommend 6 months interval periods for follow-up and for continued surveillance. If we look for the likelihood of cancer, the percentage is between 0% to 2%. It is the category 3 of BIRATS assessment category. And now it is the category 4. If we report a category 4 for the BIRATS reporting system, it is a suspicious lesion. In category 4, there are 3 basic steps. Category 4A for low suspicion for malignancy. Category 4B is the moderate suspicion for malignancy, and category 4C is the high suspicion for malignancy. And each of them have the increasing percentages for likelihood for cancer. If it is category 4A, the malignancy possibility is between the 2% and the 10%. For category 4B, between 10 to 50%, and for category 4C, it is between the 50 to 95% of likelihood of cancer. And if it is reported as the category 5, it is highly suggestive of malignancy. tissue diagnosis must be required for those kinds of lesions, and the likelihood of malignancy is over 95%. And the last one, if it is reported as the category 6, it is known as a malignant lesion, and it is reported with an biopsy or histopathological examination. The surgical excision, when clinically appropriate, is the management for the category 6 of BI-RADS classification. And if more than one type of examination, it is recommended to report both of them together for the composite results. And the sixth step of our standard reporting system is the given management recommendations. Clear recommendations must be written to our documentation of breast ultrasound report. Recommendations may include routine age-appropriate screening, surveillance imaging for probably benign mass, and annual follow-up after percutaneous or surgical biopsy and clinical management. And the last step for our standard reporting system, to communicate unsuspected findings with the referring clinicians. The verbal discussions between radiologists and the referring clinician should be documented in the report if it is needed. This is the basic breast ultrasound reporting system that the literature recommends us. And there are some examples of such kind of breast ultrasound reports. We can write first the date of the examination, the patient ID or the patient name, and clinical data, age, history, family history, indications why we do that kind of breast ultrasound examination, cause for requesting the ultrasound examination. Then we have to write our report, the tissue composition according to the ACR format, homogeneous background, exotexture, fat, or the other ones. And then we have to report the findings of our breast ultrasound report for suspicion, for new lesions, for lesions in location of clinical interest. Maybe they can be written in bold characters or with italic and bold characters to emphasize or to show that kind of extra lesions. And the lesions of both sides, I mean the left breast, and then you can write those kinds of breast specifications. And then the right breast as above all of them for the right breast. And also axillary examination also included in the breast ultrasound report and its documentation. For axillary lymph nodes, we can write all the important findings. And lastly, the last sentence is the BI-RADS, as I have emphasized before. According to the lesions, which step of BI-RADS or which BI-RADS we have to write or report. This is another example of breast ultrasound report. And also the accurate documentation must be made for the ultrasound procedure on the electronic medical record or maybe a written format. We can give the report or documentation of breast ultrasound to the patient and record in a retrievable format, PACS, picture archiving and communication system or a disk. Again, I want to emphasize that we are not radiologists. We are just making the breast ultrasound as the part of our breast examination. In basic steps, I mean, auscultation, palpation, percussion are the major breast. And today, in modern medicine, ultrasound may be the fifth step for the basic examination, and we recommend you to use the breast ultrasound as an, I mean, the part of your routine procedure of breast examination. Thank you.
Thank you for your presentation, Dr. Atagüler. Any comment or questions for third speaker, please?
Thank you for Can I ask the radiologist, is it easy to recognize the architecture distortion by ultrasound?
I'm not a radiologist, but can you repeat again, please?
Is it easy to recognize the architecture distortion by ultrasound alone, without the mammogram? To say this breast has architecture distortion?
Yes, it depends on the breast and lesion, but and also it depends on the experience of the operator, radiologist, or surgeon as an operator. We can detect in ultrasound, but in some lesions or some patients, depending on the patient problem, we need also mammogram. We report these two together. But in ultrasound, it depends on the radiologist operator experience.
Dr. Çakmak, please.
I have some cases regarding your question, and also the concordance of the multimodal imaging is very important for those kind of architectural distortions. You should absolutely look at the mammogram for the location of the lesion, and also at that location via the sonographic evaluation. If they are concordant, then you can say that this is this. But the difference or the change between the methodology all depends on the experience of the operator, and also you cannot find the correct answer for architectural distortions without pathological evaluations, because some of them is really a cancer that we see as an architectural distortion in the sonography. Okay, thank you.
Is there more than question or comment? No.
And now, Dr. Güldeniz Karadeniz Çakmak will speak about abnormal ultrasound findings.
Dear chairs, dear friends and colleagues, it's my great pleasure to be here. We have been planning and designing the Senus ultrasonographic course with this faculty for more than 5 years, and my colleagues are in the audience that we began this course. So
Excuse me, your voice is not.
I'm sorry, it's okay now? You hear me? Okay. So it's my great pleasure to be here, and I also thank all of them for all these support and contribution through this long way, and we have a really long way to go from now on. So my topic is abnormal sonographic findings, and I have no disclosures. So since this is a course, we have some kind of objectives, including we would like to recognize use sonographic abnormal focal lesions at the end of the course, list and define the sonographic characteristics used most commonly to describe abnormal breast lesions, list and define the categories used to classify these sonographically abnormal breast lesions as well, and also to identify sonographically detectable abnormal lesions of the breast and categorize them as well. So let's begin with the most readed disadvantage of the sonography, which is the operator dependence, as Professor Özçınar mentioned before, and the static view of the lesion that we consider. So it is really important to emphasize the crucial role of real-time sonographic evaluation that gives the accurate information regarding the lesion or the area we are interested in. So we know that we are going through the Barrett's Atlas, which provides standardized breast imaging terminology, report organization, assessment structure, and a classification system for all mammography, ultrasound, and also the MRI. So in general, the assessments for two examinations differ. The oral assessment should reflect the more abnormal of the individual assessment, and it has a hierarchical degree of abnormality. So before beginning, I would like to emphasize some teaching points, because regarding breast sonogram, some technical points should be underlined. As the nature of the organ is a superficial that we are dealing with, the frequency of the transducer should be higher, between 7 to 14 megahertz, and also the compression should be high to evaluate the cystic and the solid lesions, to discriminate them, and the transducer should be parallel to the inner surfaces, and we should use some multimodal approaches to get rid of the shadowing areas that might change our BRS classification. So let's begin with the masses. We'll have to look at the shape of these focal lesions first. It might be oval, as you see here. Can we have the lights off, please? Because there are lots of sonographic real-time imaging in order to make the audience see them all. As you see, it might be an oval lesion. Most of these lesions are benign in nature, usually. And this is the real-time sonographic evaluation of an oval lesion. I don't know if you are able to see it. Over there, here, it's the well-circumscribed oval lesion, and we are just getting closer to it. We are moving the depth regarding it so we can see it better. The visualization is very important during sonography, because you have to see and you have to identify the lesion that you are looking for. Or the lesions might be round, which means that the diameter is nearly equals to the longitudinal diameter, and which is a valuable feature for particularly lymph nodes. After me, Professor Gururunu will mention about the shape of the lesions in the axilla, but in the breast, these lesions might be benign or malignant. Can we have the lights off, please? And for example, this is a rounded lesion, but here are some kinds of, you see, undulations over there, which means that this is a rounded lesion, yes, but it might have some potential for malignancy. And also this lesion was a 4 millimeter solid hypoechoic mass, and the true-cut biopsy revealed it to be the invasive ductal carcinoma. As you see here, I would like to mention some kind of technical points. For example, here is a focal lesion you see over here. To have the accurate diagnosis, the lesion you are looking for should be just in the center of your screen. I mean that if you put a cross over the screen, this lesion, in order to evaluate this lesion really accurately, as you see here, it is getting closer to us, the lesion should be located in just the center of the screen, so you can also consider the diameter and the posterior acoustic features of that lesion as well. So irregularity, as you know, this is one of the most important feature of the malignant lesions, as you see over here. And speculations, also here is a lesion, hypoechoic lesion, and it has some kind of hyperechogenic borders over there. Also, it has been turned out to be an invasive ductal carcinoma. And here's the real-time sonographic view of one of our malignant patients. You see here, there's a really hypoechoic, when we compare with the adjacent tissue, mass lesion. It has some kind of posterior acoustic features, so it has to be categorized as BRATS 5 when you are evaluating it. So, to sum up, when we look at the shape, the benign lesions are usually oval or might be rounded, and if they are lobulated, they are usually determined as indeterminate, and if they are irregular as a shape, they are termed as suspicious. The second feature is the orientation, which is a specific feature for sonographic classification. Parallel lesions that are wider than tall means the mass doesn't disturb tissue planes and displaces them, or grows between them rather than invading or growing through them, which are non-parallel. That means taller than wide lesions. Parallel is more often associated with benign lesions, and non-parallel, I mean the taller lesions, are usually malignant. So here we go. Here is a lesion. The ratio of AP to lateral dimension is smaller than 1, and also this is the same. So if the lateral is larger than AP dimension, it is the benign lesion. And the real-time sonography over here, as you see, this is a lesion that longitudinal diameter is larger than the AP diameter. So, which turned out to be a fibroadenoma. So the non-parallel lesions, that means AP diameter is larger than the lateral diameter. As you see here, over there, all of them turned out to be the invasive ductal carcinomas. And also we come to the margins, it might be circumscribed or not circumscribed. So benign lesions usually have sharp, smooth, and well-defined margins, as you see all of these lesions. And then we move on. But when the margins are not circumscribed, it might be jagged, fuzzy, ill-defined, or the irregular. All of these features are supposed to predict the malignant potential of the lesion that you are looking for. And also the microlobulation is an important feature of malignancy. The undulations that we define as 1 millimeter, smaller than 1 millimeter lobulations in a mass also predicts some potential for malignancy. And the angulation at the edges, as you see here, is a well-circumscribed lesion, and also it is here. And I have also the real-time sonographic image, as you see here. This lesion just looks like a fibroadenoma, but it has some angulations over here and over here. Also, the lesion has some kind of intra-mass calcifications, microcalcs, which can be just predicted to be a degenerated fibroadenoma or something like a fibroadenoma, but it also turned out to be an invasive cancer when we got the core biopsy. Oops. I can move on. So the non-circumscribed margins includes also speculation, which is very safe and sound feature for the malignancy. In fact, as you see here, there are some kind of star-like speculations around the edges of the lesion, which is why we predict all these lesions, or we categorize all these lesions as BRATS5. And here is the real-time sonographic imaging, dynamic imaging. Here is a mass lesion. And also from the other side, we are just thinking about might there be two different lesions. As you see here, it's a very hypoechoic, well-defined but speculated margin lesion, which turned out to be a invasive breast carcinoma. So to sum up, the lesion might be circumscribed, which usually benign lesions have, or ill-defined, undular, microlobulated, and speculated. All of these features defines the lesion to have the potential of being malignant. And we move on. The second thing is the echo texture of the lesion, focal lesion that we are looking for. It might be anechoic, which means that the lesion do not have any echoes and it is absolutely black. Or very nearly black, just like here. This is a malignant hypoechoic, very hypoechoic lesion. By the way, we are defining the echogenicity regarding the adjacent tissue for the lesion, for the organ you are looking for. For example, if we are dealing with the breast, the echogenicity of the fat tissue is the reference tissue, so you define the color of the lesion regarding the echogenicity of the fat tissue in the breast. If the lesion is darker than the fat tissue, I mean here, you term it as hypoechoic. If it is absolutely black, you term it as anechoic. If it is, I will just show you later. This is the anechoic lesion. Yeah, here you see it. It is absolutely black, so we call it anechoic. If the lesion is wider than the reference tissue, that I mean the fat tissue in the breast, here you see, it might be termed as hyperechogenic, and the hemangiomas, lipomas, and also the needle that we are going to have in the afternoon session on the hands-on course is hyperechoic in the sonographic evaluation. If the lesion is blacker than the adjacent fat tissue, it is hypoechoic, as you see here, and here, and here, and also here. This lesion was turned out to be the invasive cancer. As you see, the hyper-echoic echogenicity within the mass. This is a microcalc, and also you see here the macrocalcs, and you see here the microcalcs. Of course, the real-time sonographic evaluation is more valuable than static images. And another real-time sonography for an invasive cancer with a very hypoechoic nature, and it has the microcalcs as you see here. So this hyperechoic microcalcs can be also seen by the sonography, but we all very well know that the mammography has a superiority regarding evaluating microcalcs in the breast. Or the lesion might be isoechoic, as you see here, here, and here and here. It's very difficult to differentiate these lesions from the adjacent breast tissue, so we call that isoechoic. And the isoechoic lesions are 85% benign lesions, and it's very difficult to assess these lesions. So we use compound or harmonic imaging to evaluate these lesions during sonography. The lesion might be heterogeneous. Here is an heterogeneous. When we compare with the adjacent breast tissue, you can say that it's a hypoechoic mass and a solid lesion, and it has some speculations regarding the edges, but it has some other components. As you see here, there are different bright colors, or there are different color images within the mass. So these lesions are termed as heterogeneous, not the homogeneous. And also here you see some kind of cystic spaces in a mass, and over here a cystic space, cystic space, cystic space. And when we evaluate the whole mass, we have to term it as heterogeneous. And also the complex lesions, it's very important. This is a cystic lesion, and it has a papillary lesion, a solid papillary lesion in it. And this is one of our cases. It's also cystic component over here, the black area, and it has a solid component in it. This patient turned out to be a intracystic papillary carcinoma, which has really a bad prognosis regarding it. And also the cystic and solid lesions together, so you should be very careful about the solid component in a cystic lesion. Some of them are really very difficult to differentiate from the complex cysts. But if you have a solid component, and if when you look at the Doppler view of the lesion, if it has some kind of vascularity in the solid component, so you confirm that it is the solid part, and when you are going to biopsy them, you should take the course absolutely from the solid part of the lesion, otherwise you can miss the diagnosis. So this is the view of a cystic lesion here, and it has some kind of solid mass in it, a septa in it. It has turned out to be complex cyst, not a malignancy. And also here's another view of an invasive carcinoma. You see it, the jagged angles, margins, and also the microcalcs in it. So other feature is the posterior features of the lesions, the attenuation characteristics of a mass with respect to its acoustic transmission also have some kind of additional value. And with the posterior features, unfortunately, it has little specificity to predict malignancy. So the lesion might have no posterior acoustic features, as you see here, or it might have some kind of enhancements that we usually see in the cystic lesions, because all the sound waves are transmitted, not reflected. It means that here we call it the enhancement, and it has some kind of edge shadowings. It is turned out to be a cyst. And here's also a cystic lesion with particular posterior acoustic enhancement. The questions are for the shadowings, because they are usually predict malignancy, posterior shadowing. This is a hypoechoic mass with a very speculated, ill-defined margins, I can say, but it has a really posterior acoustic shadowing. And this is also a mass lesion with a posterior acoustic enhancement, but it has some kind of edge, one edge shadowing. This is a also a predictor of, might be a predictor of malignancy. And also here you see the posterior acoustic shadowing for the lesion, and this lesion is very, very tough, very, very solid, so there is only we can see the shadowing of the lesion, not able to define the lesion by itself. I'll show the real-time sonography of that lesion. Also, this is a 2 millimeter lesion that we have during the diagnostic sonography. We only see it, the shadowing, and then we evaluated the area and find a 2 millimeter invasive ductal carcinoma adjacent to the shadowing area. So here we see the posterior acoustic shadowing of a lesion, a very solid and a very black lesion. Nearly we can say that as anechoic because it is very, very solid lesion when we compare it to the adjacent breast tissue. And the lesion might also have some kind of enhancement and shadowing. So we call this the combined pattern. The combined pattern is sometimes predict malignancy, but also you have to take course from the solid part of this lesion as well. So when we come to the microcax, the microcax is an important issue for sonography. The best characterization of the microcalcification is realized, of course, by the mammography, we know that. But we can realize the calcifications if a mass lesion is presented, or if your resolution of the device is very high. As you see, there might be homogeneous lesions with internal echoes that are not termed as microcax. Do you have to discriminate these? And also, there might be some heterogeneous calcifications which is concordant with mammography and here. And also, there might be some mass calcifications in a mass. Here you see the hyperechoic foci here. And all these patients were turned out to be malignant cases. And the real-time sonography of a mass lesion with the microcax, as you see here. It has also macrocax and the microcax together. And also we are dealing with the DCIS, as you know. If you have some intraductal calcifications, these should be defined as BRS 4 or 5 regarding the mammographic assessment of the lesions and the microcax that are distributed through the ductus as well. And when we come to the associated features, we have some kind of different features of these lesions. As you ask, according to your question, these are the architectural distortion lesions. But when we look at these lesions, we could not define them as architectural distortion or malignancy. So we have, when we see these images during our real-time sonography, we have to get some kind of course from these lesions and confirm that it is some kind of radial scar, or if it is, as you know, larger than 1 centimeter, it might be defined as complex sclerosing lesions. And here we go. Some kind of ductal changes over here, the ductal ectasias. If you do not have any kind of intraductal macrocax or intraductal solid masses, you do not need to get anxious or worried about it. Here is the static image of the ductal changes. So we have, of course, the edema. It might be due to the malignant lesions, including inflammatory breast cancer, but also the benign situations like mastitis, and also in the post-radiotherapy situation. Let's move on. And also the vascularity, qualitative, here we go. I would like to show you some Doppler images. Qualitative color Doppler or equivalents, I mean color flow or mode, and the power Doppler are the anonymous recommendations for the vascular lesion characterization in the breast. There are no vascular or just a hypovascular mapping, unfortunately, in benign, and a hypervascular imaging in the malignant lesions. So if the lesion has some kind of vascular structure over it, we can say that it's a solid lesion, so we have to sample it. As you see here, there's a lesion, and over it we have some kind of internal vascularity, and there's a lesion here, and it has some kind of vessel in the rim. All of these lesions should be sampled to get the diagnosis. And muscularity also is helpful for us. When we look at this static image, we can see that it's a well-shaped, hypoechoic or anechoic nearly mass lesion with a posterior acoustic enhancement that could be termed as a cyst. But when we look at the Doppler mode, we see that the lesion has some kind of internal vascularity, and when we sampled this lesion, it turned out to be an invasive ductal carcinoma. Compressibility is another important point that has been included in the breast barriers classification. We can talk about it hours and hours, but usually, as a basic thing, you have to know that benign lesions is compressible, and usually malignant lesions are not compressible. So regarding adjacent architecture, for the benign lesions, the adjacent architecture are usually unaffected, or sometimes might be stretched just like here and here. But for the malignant growth and the malignant invasion, when you look at the adjacent tissues, you see that they are interrupted. For example, we see the Cooper ligament here with a hyperechoic band, and we cannot just follow the Cooper ligament in the or around the lesion. So they have special cases. Let me move on to summarize all these things. What do you think regarding my all definitions at the end of the lecture? This is a lesion with sharp margins, as you see here. It is lateral diameter is larger than the AP dimension. It has some kind of posterior acoustic enhancement, and it's an anechoic lesion, and it is homogeneous without internal echoes. So I would like to comment on this. What is this? Yes, it might be a cyst. It's usually it has the features of the benign lesions, and it should be categorized as benign in the Burrett's sonographic lexicon. Yes, this is a cyst. So we move on. And a lesion with the smooth margins, also lateral dimension is larger. It has bilateral edge shadowing. It's hypoechoic when we compare with the adjacent breast tissue. And it has some kind of homogeneous internal echoes. So regarding these features, what is your comment? It is a benign or a malignant lesion, for example. Benign. And yes, this lesion is turned out to be a fibroadenoma. So when we come this lesion, it's a very small lesion. It has some kind of irregular borders, as you see here. Its borders or margins are also indistinct. It is a taller lesion when we look at it. It is hypoechoic when we compare it to adjacent breast tissue. And it has some kind of here posterior acoustic shadowing, not the enhancement. And it has some kind of microcalx over here, I mean heterogeneous internal echoes. So when you look at this lesion, it's a small lesion, of course, your first thought might be it is malignant, and it is turned out to be an invasive cancer, you're right. So these are the lesions with some kind of posterior acoustic enhancement. They are anechoic, they have good margins, smooth margins that can be easily defined, and also these. And these lesions are the clustered cysts, so they have no clinical importance. And this lesion, this has some kind of good margins. We can just define its margins. Here we see it. It has some kind of hyperechoic integrant over here. So what might be this lesion be? Or this one also, it has some kind of internal hyperechoic foci in that. So you have to have the physical examinations for these patients. Of course, this might be a mass with a solid component in it, but if she has some kind of, for example, edema, pain, that means that looks like some kind of abscess or mastitis just going to abscess, this might be due to that. But also, this might be the complex part or the solid part, and this lesion might be an intracystic papillary carcinoma. So the physical exam and the other imaging modalities are very, very crucial for breast lesion imaging. So what is this? I would, yep. She has some kind of nipple sparing subcutaneous mastectomy. We are in the era of implants. So this is the view of an implant patient. This is the dermis. The fat under the dermis is very, very little, and all this area is the implant and the saline in the implant. So it's very, very important to have your patients, particularly the patients with implants, because as you know, there are some kind of cases with the ALCB in our decade. So if there is some kind of seroma, I mean it's liquid over the implant, it might predict that this might be an anaplastic B-cell lymphoma. So the seroma around the implant is very, very crucial currently. So in an analytic way of view, when we evaluate the focal lesions of the breast, we look at the margins. If they are indistinct and jagged, it predicts malignancy. We look at the retrotumoral acoustic phenomena. If it is irregular, posterior shadowing, unilateral edge shadowing, it might be malignant. When we look at the shape, if AP is greater than the lateral dimension, it might be malignant. The adjacent structure or architecture, if the lesion disturbs the adjacent structures, it might be malignant. And the composition effect in the internal echoes revealed that if there is some kind of microcalx in a mass, it might be also malignant. When you have also to look at the mammographic views as well. So regarding diagnostic breast sonography, you have to take into the most malignant feature, sonographic feature, to define the lesion. If strict benign criteria not met, we should classify the lesion as indeterminate. As you see here, there are focal lesions. This is a simple cyst, complex cyst with internal echoes, complex cyst with septas in it, or a complex cyst with mural nodule. And if, for example, here is some kind of vascularity, this also might predict your lesion to be a malignant one. And also the solid mats with a regular shape, we can just see the adjacent structure over the lesion. These are all probably benign features. But when you have some kind of indeterminate lesion in a mass lesion during the sonography, I mean that if a lesion has some kind of internal echoes, for example, that you could not understand, it should be defined as indeterminate, because the gold standard method to find the diagnosis, as you know, is the pathologic evaluation of these lesions. So if any malignant feature presents in a mass, we classify as suspicious. What are these malignant features? Indistinct, jagged or fuzzy margins, irregular posterior shadowing, hyperechogenic with heterogeneous internal echoes, AP dimension larger than lateral dimension, and these are suspicious for the focal lesions, as you see here over the static images of the 2 dimensions of our mass lesions. All of these turned out to be invasive ductal carcinomas, and also these. Maybe I could emphasize that some of the malignant lesions have some kind of benign sonographic features. For example, some mucinous tumors look like just like this, isoechoic or hyperechoic with good defined margins. So tumor biology also predicts the sonographic features of the lesions that we should also take into the consideration and keep in mind. So I mentioned it many times, but it's very important. You have to know the indeterminate complex cysts and also the suspicious lesions of the suspicious features in a lesion. All of these should guide you to core biopsy that lesion without follow-up. So summary for the classifications of solid nodules: look for the malignant characteristics during your sonographic evaluation. A single malignant feature requires probably malignant classification. If strict benign criteria are not found, then you should classify that lesion as indeterminate, and the slightest question about characteristics require an indeterminate classification. So we are in the era of the value-based care. So during our period, the quality and the cost is very important. So the quality of the service we are giving depends on the outcomes, safety, and the quality of our service. So we have to improve our value of care and also the quality, and also we have to decrease the costs because the resources are limited all over the world, and we should have a global perspective using these resources. So the technology is getting higher and higher, improving. Now we have hands-free sonographic evaluations in our hands, and also we use these technology during our operative procedures, and we can see these from Wi-Fi in a large screens in our operating rooms. So sonography is something that a breast surgeon really should have in his or her routine clinical practice. But of course, education is the key. Ultrasound is the most operator-dependent imaging modality for the breast. So you have really very big chance, unfortunately, to miss the lesions. If you are making or performing some kind of ultrasonography, you have to get the absolute training experience, and also you have to collaborate with your colleagues. So if you are a breast surgeon, so the ultrasound is not just an order that we only read the report that's given by our colleagues. Focused ultrasound is a major component of breast physical examination. Currently, static images are difficult to evaluate. They are usually blurry and do not provide, unfortunately, sufficient data for us to design our way to help our patients. And also real-time dynamic imaging of the breast is an invaluable tool for a breast surgeon to find his or her way. But in this road, we have to be, in this path, we have to be really very careful that we have to collaborate with our radiologists because we are stronger together. And this is a work of multidisciplinary team. So we are as good as our pathologists and the radiologists. So the collaboration with your radiologist is of paramount importance. But there is a change in surgery and also change in value-based care. So I would like to invite all of you our Senus course that will be held in October 21, 22, 2023 this year with our national tutors and trainers, of course, and also with our international colleagues that will also enter this team this year. These are some books that I would like you to have if you are beginning this work. And also, I would like to thank for your attention and would love to answer your questions if there is any. Thank you very much.
Thank you very much, Dr. Takmak, for your excellent presentation. As always, light on, please. Işıkları açalım. Is there any comment or questions from audience? Thank you so much for joining. We close the session and go to coffee break.
listen, first of all, Cem Yılmaz, and he's going to explain us the image-guided interventions. Thank you.
Thank you very much. Hope you enjoyed this conference for 2 days. It was a very busy agenda for you all, but I know that very fantastic lectures were given. Unfortunately, yesterday in the morning I wasn't here with you, but I followed it through YouTube, so that very interesting lectures and key points that were given to you, so that I hope you enjoy this meeting. And today I'm going to talk about the basic interventional breast ultrasound for breast surgeons. First of all, I would love to begin with the philosophy of it, because I know that in many countries there are lots of restrictions about the use the ultrasound in the hands of the surgeons. And according to the European Academy of Senology, a breast surgeon must be qualified in breast oncoplastic surgery at least level 1 and level 2, breast oncology, mammography and MRI, breast ultrasound, both perioperative and postoperative usage, and breast center finance, breast surgery and oncology actual literature. And the radiology is the main department for the breast care. For screening, diagnosis, surgical decision, neoadjuvant treatment decision, radiology is mandatory. Breast surgeon has to understand what the radiologist is describing in the report. He has to analyze the report and understand the 3D coordinate of the current situation. As we all know, breast is a three-dimensional organ, so that we need coordinates to remove the microcalcification, remove the tumor, and we have to understand what the breast is going to look like after irradiation, so that at least mammography and ultrasound must be must be in the hands of the breast surgeon, so that the breast surgeon must know where the tumor is in the three-dimensional coordinate of the breast with mammogram. And the breast surgeon is a breast surgeon, and breast radiologist is a radiologist, but they both work for the effective treatment of the patient, so that we do not play the role of the radiologist, so that but we need ultrasound in our hands. A breast ultrasound report is a dynamic report that describes actual situation of the breast, so that the radiologist describes you a tumor in the upper outer quadrant. He can tell you that it's a 2 o'clock region, but in the operating table, you may find it in the 3 o'clock or 4 o'clock region. So that we must have a common language speaking with the breast radiologist and the radiologist. But in order to understand the report, because the breast radiology report is a dynamic report, so that you have to see it through your eyes during the operation and before the operation. And the reported pathology may vary from one radiologist to another. Even the position of the lesion may vary from one radiologist to another. During reporting of the ultrasound, the position of the patient may vary from one doctor to another, because one surgeon may prefer to operate a breast simple mastectomy with the closed arm. I saw it in India, for example, they were operating with closed arm, and we operate when the arm is open. And the report mainly comes to the table of the surgeon only as a written report. Visual documentation is mainly missing in daily practice. There is only description and location knowledge and comments about the lesions. So the surgeon must understand the report, the location of the lesion, neighboring anatomical features, depth of the lesion and muscle and skin relationship, radiomics of the lesion, which type of lesion it is. It can be luminal type or triple negative or HER2 positive. The surgeon must at least have the knowledge to discriminate between the different biologies of the tumor. And other lesions which are not malignant but may be neighboring the cancer. I'm giving some support to some insurance companies and also some law offices. And most of the law offices send me the reports about whether it is malpractice or not. The patient has breast cancer, but the patient is operated and the fibroadenoma is resected, but the tumor is still inside. And when we look at the operation keynotes, we find that the operation is not performed under ultrasound and under the guidance and the help of the radiologist. so that the tumor neighboring fibroadenoma is resected, but the invasive carcinoma is still inside the breast. So that ultrasound in the hands of the breast surgeon solves plenty of problems. And it is ultrasound in the hands of a breast surgeon, it is mandatory, according to many international main board committees. Developed countries in Germany, Japan, UK, USA, France, Spain, etc. solved conflicts between the breast surgeons and the breast radiologists. So that we have to insist on using ultrasound in the hands of the breast surgeon. And how the breast surgeon must use it? To understand the report of the radiologist, in the preoperative planning, in the follow-up during neoadjuvant chemotherapy. I'm a little bit lucky because I was trained both in Turkey and both in Germany and Italy. In Italy and in Germany, most of the chemotherapies, neoadjuvant primary systemic treatments were given by the gynecologists and oncological surgeons. So that during the follow-up, every 6 weeks, the patient is examined by the radiologist, by the surgeon himself or herself, in order to understand the downstaging of the tumor as they were receiving the neoadjuvant primary treatment. And in Turkey, unfortunately, our medical oncologists, they do not know breast ultrasound. They only palpate the breast, they only palpate the lesion, and they try to understand the downstaging with mostly in the axilla. But the axilla may not be a good response picture to the doctor, because the axillary downstaging may be the pattern may be different from the breast the tumor downstaging. So that during the neoadjuvant treatment, the surgeon must use the ultrasound as a powerful tool. And during the surgery, even in mastectomy, to understand the neighborhood, post-operative care, seroma infection, drain management, in the follow-up after surgery, and after irradiation to manage the skin problems and seroma problems in the axilla. So how we use the ultrasound for the interventional procedures. There is a very, very good 4-step rule for you, because after the theoretical session in the mini senus, we will give you some practical practical training about how we are going to use the interventional procedures with the ultrasound. There's a 4-step. It's very simple, both for wire guidance, wire application, both for core biopsy, both for the clip insertion, and both for the true cut biopsy. First, fix the target, get the perimeter security, check the surrounding of the lesion, whether there's a costa, whether there is a muscle, whether there's a vessel. We will show you in the practical session. And the third, fix the angle and fire. Whether you perform core biopsy, whether you perform fine needle aspiration, and whether you are putting a wire or putting a seed inside the tumor. It's a very simple 4-step that every surgeon can handle it. Core biopsy. As you see here, we fix the tumor with the ultrasound. We take a picture in the screen. We watch the screen, and then we put the core biopsy in the right angle, and then we fire it, and we have our core pathological tissue in our hands. So that we will, after the theoretical session, we will perform plenty of those true cut biopsies with you. And final aspiration, it's the same. Fix, check the parameter, and check the angle, and fire, so that you will aspirate whatever you have. And it can be an abscess, it can be an infection, it can be a granulomatous mastitis abscess, or it can be a complicated cyst. And also viral localization. It's the same rule. Fix the target, get the perimeter security, fix the angle, and fire, so that every surgeon can perform it in the office. It takes only, for the non-palpable lesions, it takes only 3 minutes to perform a wire guidance. So, during the operation theater, what we do in the operating theater, we collect all the images that is given from the radiologist to us about the tumor. We know where the tumor is in the mammogram. We know where the tumor is in the MRI. We know what it looks like, in the ultrasound. And then, during the operation, we'll check the wires, where the tumor is located or the microcalcifications are located. Sure. Işıkları bir kapatabilir miyiz? Hı hı. Hı hı. Hı hı. Hı. İyi. İyi. We check the wires. And there's another tip. My breast radiologist is Erkin Arıbal and Levent Çelik. With Levent Çelik, we have performed more than 1,500 wire-guided surgeries. And at the beginning, we had some problems of not finding the lesion, not finding the microcalcifications, and the misguidance of the wire. It can move. The migration of the wire was a very huge problem for us. So that we started, as the breast is a three-dimensional organ, so that now we are putting two wires. One is in the x-axis, one is in the y-axis. And after we started this procedure, we haven't missed any single microcalcification. We haven't missed any single seed. We haven't missed any single tumor inside the breast. So that in a three-dimensional organ, when you put two wires, one from the x-axis and one from the y-axis, you can perform 100% successful wire-guided resection of the tumor. So that how we do it, we follow the wire under ultrasound with our mobile devices. This is a Clarius L15 L15 device, 15 hertz device, so that it's very affordable. It's very cheap machine, so that you can even use it with your iPhone or your tablet or your iPad, so that the image is very high quality, and the image response rate and the frequency of the response frequency when you're performing a lifetime surgery, so that it's real-time surgery, so that it's so easy to communicate with the machine and the probe and your tablet and your iPhone. So it works very, very well in the operating theater. And how we do it, I will show you. Now we resected the tumor. We send it to the mammogram. We see the microcalcifications in the two axes, and the operation is done. With the glandular rotation flap. And another type of surgery. For that, you can put in the axilla mag seat or in the breast mag seat, magnetic seat, and you can use both magnetic tracer plus the ultrasound in the operating theater. This is the before neoadjuvant, after neoadjuvant. There's not a good response of the tumor. As you see, our software tells us that it's only 50% of downstaging. Before the neoadjuvant treatment, we put the mag seed in the axilla. This procedure was performed in our unit. We put the mag seed, and after 6 months of neoadjuvant primary treatment, we took the patient to the operating theater. The response was not so good, but you see in intraoperative phase, you see the signature of the image signature of the lesion, of the tumor, and then you resect it. We put the wires ourselves in the office, not by the breast radiologist. We follow our own wire. There was a clip, but this was not mag seed, but in the axilla you will see mag seed. And the magnetic seed. This is a Centimag device that can find magnetic seed and nanoparticularized liquid on iron when you put in order to find the axillary lymph nodes. Here you see the device now is locating our axillary lymph node. These are plastic devices because this is as this is a magnetic procedure, you cannot use metallic devices. And then now we found the lymph node. Here it is. When it says 999, you find it. And after we resect it, after we resect it, we again let the machine to count it to find whether it was the initially marked, the MAC-seed marked the lymph node. So, and how we use the ultrasound in the follow-up for the seroma management, axillary complications management, infection and abscess management, and possible recurrence management. And in our clinic, every year we perform more than 3,400 ultrasound examinations, both preoperative, both postoperative, and for the markings. So that we highly recommend you to come and visit our clinic every day, nearly for more than 40 or 50 cases, different cases. And we now we have the artificial intelligence for the mammogram, and now we are planning to implement the artificial intelligence for ultrasound in our unit. So you're all welcome to our clinic. And thank you very much. And as a conclusion, a breast radiologist is a radiologist, a breast surgeon is a breast surgeon, but ultrasound is a device to increase quality, decrease service speed, and solve complications and prevent complications. Conflicts between surgeons and radiologists can be solved with frank conversations, and thank you very much. Any questions?
Thank you, Dr. Yılmaz, your excellent presentation. And the second, in this session, the second speaker is Dr. Mustafa Ümit Uğurlu from Marmara University Department of General Surgery. The topic is ultrasound in surgery. Yes, Dr. Uğurlu, we are listening to you.
Thank you very much. Since I'm the last tutor and we have all post-meeting liturgy now, we're dealing with it. I'd like to, may I have your attention? I'll try to wrap up all the talks that the other tutors described. So I'll talk about the philosophy of ultrasound in surgery. Nothing to declare. So a survey comparing the utility of ultrasound among surgeons in different subspecialties of general surgery showed that the breast surgeons have the greatest ultrasound and ultrasound guided biopsy usage. There is a preponderance of breast surgeons that have access to the ultrasound, and they perform at least one ultrasound in a month. So the breast surgeons use the instrument well, but the question is, why should we perform ultrasound in our clinical setting? Is it for diagnostic purposes? Actually, my answer is no. A complete diagnostic workup is the responsibility and the liability of the radiologist, not the surgeon. We use ultrasound adjunct to the clinical examination and for precision of our surgery, and I think to reach a level of perfection, since we have the major concern of over-treatment and under-treatment during surgery. So in a trial, they questioned the concordance of tumor size using different radiological tools, including mammography, ultrasound, and breast MRI. Hence, the post-op pathology size with the principal investigator's tumor size. For T1 and T2 tumors, ultrasound was found to have the highest concordance with the post-op pathological side, and mammography, it was shown that mammography underestimates the T1 tumors and overestimates the T3 tumors. However, there is a major drawback of ultrasound, is that it's a very observer-dependent utility. In tumor sizes below 3 millimeter, the detection rate of ultrasound is 20%, and the sensitivity of the ultrasound is around 98% when a lesion is done by, interpreted by a faculty member, and the sensitivity decreases to 58% when it is done by a junior resident. So we need training and practice on breast ultrasound, as the previous tutors talked about. So we comprehend the major drawbacks, but as a surgeon, we just focus on a particular lesion or region which is declared as abnormal by an imaging study, and we should be questioning our findings with a dedicated breast radiologist. So we all need a radiologist to question the findings and to collaborate. So they talk about the virus lexicon descriptors. We do precise assessment of the lesion using these virus lexicon descriptors, and we evaluate the location of the lesion just relative to the surrounding structures when we use pre-op ultrasonography. So to sum up, we start from the normal regions before focusing of the abnormalities. As we all know, the upper gray layer is the skin, and then there's a mixture of fat and glandular tissue. There's the strip layer, we call it pectoralis major muscle. Then you see the ribs, and the posterior or deeper to the ribs, there's a black area, or we call it posterior shadowing. And the air in the lungs reflect most of the sound waves. It results in bright or hyperechoic line. That's the line with a dirty shadowing posterior to it. So this is the basic ultrasound that we should learn. Then within the same breast, we can obviously have the areas of glandular tissue and the fatty tissue. And within the normal ultrasonographic features, we try to find out some pathological features. So they talk about the features. We can have the cysts, fibroadenomas, and the cancer and the normal glandular tissue within the same patient's ultrasonographic imagination. So axilla, for the axilla, we have moderately sensitive but a specific, very specific instrument. We just search for the morphological signs which indicate alterations as diagnostic criteria. They are the general shape, the aspect of the cortex, the hilum, and the vascularization of the axillary lymph node. But just keep in mind that the size is not a true diagnostic for the axilla. As we all know, the axillary lymph node is smaller than 10 millimeter. It has a smooth, well-defined contour, and the fatty hilum with a thin and uniform hypoechoic cortex, which is measured less than 3 millimeters. So this is the normal axillary lymph node. As you all see, they are small-shaped unless they are reactive. They are hypoechoic structures with a hyperechoic hilum center. And when you shift to the Doppler function, you can trace the vessels within the fatty hilum. So it shows, or it demonstrates, a benign axillary lymph node. So when you just focus on the benign lymph node as an illustration, you can see that the cortex diameter is less than 3 millimeter, and it has a hyperechoic fatty hilum. So in the malignant lymph nodes, there is thickening of the cortex, like here, or there can be global hypoechoic structure, a rounded lymph node, or you can see a malignant lymph node with eccentric cortical thickening. So this is very typical malignant lymph node that we can see during ultrasonography. So in the pre-op setting, if you are the new beginner, please take your patient to the breast unit and recheck the breast and the axilla with your radiologist. Please be familiar with the mass and the surrounding to do a precise surgery. So we take our patient to the breast unit, and we make a global ultrasonographic visualization. Then we freeze the image. When we find the mass, we will find the mass soon here. Just we found the mass, then just freeze the image, measure the size of the lesion, the distance of the lesion to the skin, distance of the lesion to the pectoralis major fascia. Then you can have a preview of your surgical excision volume before the operation. I recommend you to use orthogonal localization. as we all know that considerable percentage of the breast lesions are non-palpable. So in the pre-op setting, in the supine position, and in the hands open position, just localize the lesions under ultrasound. And instead of using a guide wire, you can localize the lesion and keep marking with a pen which is closest to the lesion. There are lesions that are too, and we put a small skin mark during the intraoperative ultrasonography. So this is a beautiful trial that Dr. Chuck published in the breast. They showed that you can just determine the tumor margin under real-time ultrasound, and you can confirm that you excise the lesion using the specimen ultrasound, and you can check the tumor bed. I think they regularly do the monitoring, and they showed that identification of the involved margin via ultrasound is possible in more than 87% of the cases. And it's higher in the non-palpable lesions, it's up to 100%. And using ultrasound-guided lumpectomy, it's shown that it decreases the re-excision rates that they reported is around 2.4%. So we will, in the hands-on course, we will do the axillary clipping. So we do axillary clipping before the neoadjuvant chemo treatment. So this is the technique that we do during the axillary clipping, and this is the view of the axillary clip after we put the clips to the axilla. So this is a view of axillary malignant lymph node here. Then we put a clip on the lymph node, and after the termination of the neoadjuvant chemo treatment, you can see a fibrotic lymph node, and sometimes it's harder to visualize the clip within the lymph node. So we generally, following the neoadjuvant chemo, we localize the lesion, and this is the lesion, and this is the axillary lymph node using a guide wire. And the radiologist put the guide wires just before the surgery, and then we do the resections, and we check the clips if they are in place with the X-rays. And this is the guide wire, and this is the last view of the guide wire, as we all know. But it's nowadays is questioned because axillary guide wiring may be challenging depending on the localization of the clip lymph node. And this is a very pragmatic trial showing us that ultrasound, you can excise the clip node following neoadjuvant chemo using the intraoperative is feasible, and they are successful in 100% of the cases. So if we can use to excise the clip lymph nodes or clip the lumps or clip lumps after the neoadjuvant chemo treatment, this is a very practical recommendation, a trial from the Far East to avoid getting lost in axilla while searching for the clipped lymph node. They put a skin marking in the closest localization to the clipped lymph node. Then they introduce a needle into the lymph node under ultrasound. Then they make the axillary excision. Then, since the needle has no hook here, they place a stitch at the base of the needle, and they use a stitch and they excise the clip lymph node, and again they check the presence of the clip within the lymph node. So it's very practical. Just you don't need the needle, but you can put a skin tag here, and just you can follow this marking, and you can find the lymph node, and you can check the lymph node whether it's clipped or not after your surgery. So lastly, in the post-op session, we use ultrasound. In the post-op setting, we can have seromas, or we can have organized hematomas that they need drainage. Seromas can be cystic, so you know the ultrasonographic features of the cyst. So it's an anechoic fluid collection here. Mostly after mastectomy, the collections are multilocular, like this. And around the implants, you can see fluid collections. and you can just put a needle on it and drain the collection using the ultrasound in your outpatient setting. So we have to describe the overall composition of the breast in the probe setting. You should be rechecking the radiologist's finding before the surgery and do the skin markings in the supine position. In the interop setting, you can just replace guide wiring for non-palpable clip lesions or lymph nodes. And in the post-op setting, you can do basic punctures under ultrasounds. You can use ultrasound to drain seromas, organized hematomas, and the collections. So thank you very much for your patience.
Thank you very much, Mr. Uğurlu. Is there any question? Okay, now on we finished this part, I think, and we goes on in the downstairs for the hand-assisted course. Thank you very much, everyone. See you.